a consultant plastic surgeon in Edinburgh. I'm the immediate past chair of BFIRST, and we are very excited to partner with our colleagues from Touching Hands, Research International, and Ganga Hospital. So before we begin, a couple of announcements. Your audio will be muted during the presentations, so we won't be able to hear you. Please use the Q&A function to ask questions. Please do not use the chat function. You can use the chat functions to post comments, but not questions and answers. To submit your questions to the panelists, questions as you can. If possible, the questions specific to the sessions being presented, so we can but send in any questions, just that we may not discuss it there and then. And it will be available on the BSSH and BFIRST website later on. We will be conducting polls during the session, also makes the webinar more fun. Fill in after the seminar. Certificates will also be sent out to you in due course. Now, in case of any technical difficulties during the webinar, please email emma.brighton@bssh.ac.uk. Now, we found in the past when people have problems hearing or seeing the presentations, they just simply log out and log in again, and that usually works very well. So, we really hope this symposium will be very useful to every one of you. And for this reason, this two-part symposium, we've lined up a very exciting panel of national and international speakers and moderators. And we're very grateful to each and every one of them for participating in this. Just a reminder about the program today, which is on the website. We have 3 main sessions. The first session is on we're going to start with a talk on embryology, and then the first session is on syndactyly, which is the commonest problem people reported seeing in their practice. And then this is followed by a session on macrodactyly, which is another common and very difficult problem. And then finally, we're going to have a miscellaneous session where we'll look at recognizing patterns in congenital hand differences, followed by a talk by Dean Boyce about very common conditions. And then we are delighted that Abraham and Shilu are able to share with us their experiences in Ethiopia and Nepal. I'm sure many of you will find their talks very useful. And then we will have a very exciting complex case discussion at the end, where we invite all the panels to participate. So without much ado, I want to invite Sarah Tucker, who is the current chair of BFIRST, to come and say a few words. Sarah, please.
Thank you, Wee. Welcome to everyone, and thank you for joining us. As the chair of BFIRST, I just want to welcome you all to this webinar. We're very grateful to Wee for bringing this together as a collaboration between BFIRST and BSSH, but also many thanks go to the organising committee and those that have worked behind the scenes to make it all happen, as well as Wee has mentioned, we have an international faculty joining us today. Thank you all for giving up your time in this way. Some of you will have been participating in these BFIRST and BSSH webinars for a long while and will know who we are and what we do. But for those of you who might be joining for the first or second time, you'll only have seen this activity since COVID came and changed the way that the world interacted. So for those that haven't been with us long term, I just wanted to introduce BFIRST to you and say a bit about what we stand for and what we do. We're a charity that aims to work in partnership with local surgeons who are in less well-resourced environments by training and empowering them. We don't see ourselves as the owners of all the expertise, and we don't pretend to be in a position to tell our partners what to do. We aim to support our partners to develop their own service, and we expect them to become leaders in the field themselves in the future. We do all this through a number of different means, some of which, like visits and fellowships, are not possible at the moment, but we are increasing our virtual support to make sure that we're still there for our overseas partners. And you'll notice there are many people involved in this webinar who are the very people that work as our partners in these resource-poor nations. So if after being a part of this webinar and hearing about the work of BFIRST, you want to become more involved in partnership with us, feel free to contact us, which you can easily do through the BFIRST website or by emailing info@bfirst.org. So again, I'd just like to really welcome you to the webinar today. I'm sure it's going to be really positive and very useful. And without delay, I will hand you back to our chair, Wee Lam. Thank you.
Thanks very much, Sam, for our first session. This will be co-chaired by myself and Pedro Santos. That is Pedro Santos. He is the sole plastic surgeon at Provincial Hospital in Mozambique. He was born and raised in Mozambique, in Brazil, and he traveled to many countries during his training. He was the BFIRST Fellow in 2016, and currently he collaborates regularly with multiple organizations. And that's going to be on embryology, a quick overview of embryology and classification. So, Emma, please. Thanks.
Sorry, bear with me 2 seconds. The screen's not showing when I go to share screen. Just 2 seconds.
So, good afternoon. I'm going to spend 5 minutes just on the introduction, embryology, and classification of congenital hand differences. Now, congenital hand differences are not uncommon. It's estimated about 1 in 200 newborns are born with this. The majority are isolated, sporadic, and non-syndromic, but some of these are not. And it is important to recognize patterns and associations, and that's why we have a talk on this later on by Jill Smith. So as a congenital hand surgeon or as a hand surgeon, we have the responsibility to not only improve the function and form of the upper limb, but also to support the family. That means we have to learn surgical skills, design pathways, understand the etiology, and also communicate with others about research avenues. So a very brief overview of embryogenesis, an extremely complicated topic. So limb formation happens really between 4 to 8 weeks. And by 8 weeks, the hand is actually formed, and then this will grow to term. Now, the position where the upper limb comes up from the body is not random. It's precisely controlled so that it doesn't come out wherever it wants to come out. And this is controlled tightly by transcription factors. And as the upper limb grows, it is programmed in 3 axes, and each of these axes has what we call a signaling center and a responsible protein. So the proximal distal axis is controlled by the apical ectodermal ridge, and the protein is fibroblast growth factor. The posterior anterior axis or ulnar radial axis is controlled by the zonal polarizing activity, and the responsible protein is sonic hedgehog. And then it is difficult to visualize, but there is a dorsal ventral pathway, and this is via the WNT pathway. Now, if you're like me, you may find it hard to visualize, and that's why I hope this animation would help. So that's the AER and the ZPA in the developing limb bud. And then on the dorsal ectoderm, there is a signaling center, and these 3 pathways interact with one another to cause growth of the upper limb. So sometimes things can go wrong, and what causes these developmental errors? And as a result, we can get either too many fingers, too big fingers, failure to separate, which means syndactyly too small or too few. Now, a lot of the research was done using the silky chicken. So this is the chicken limb. And then with manipulations of the different signaling centers and proteins, this resulted in various malformations, which we then extrapolate to human conditions. And that has led to our current understanding of embryogenesis and why things go wrong. So this summary slide really captures everything I've said so far. And for trainees out there, this is all you need to know for your exams. Now, we have to spend some time talking quickly about classification. Classification can be general and specific. So general classification used to be the Swanson's, the 7 classification. However, this has been replaced by what we call the Olbert-Mensky and Tonkin classification. The Swanson attempts to fit into the timeline of embryogenesis and combine this with morphology, which means what we can see, but often it is difficult to do this. So as mentioned, the Olbert-Mensky and Tonkin classification has replaced the Swanson's as recommended by the IFSH. It has 4 main groups: malformation, deformation, dysplasia, and syndromes. And this again fits nicely into embryogenesis, with malformation happening within the first 4 to 8 weeks, and deformation and dysplasia after the limb has been formed, and syndromes happening before. So this is the general classification, and it allows every condition more or less to be given a specific group within this classification, and this has allowed us to speak with one voice much easier. Now, it is still a difficult classification, and for this reason, we have designed what we call the OMT Medical Reference App, and this is available for free download via Google Play and App Store, and I really encourage all of you to download this app. It contains lots of photographs and information for congenital anomalies. And so finally, classification for specific conditions. I'm not going to talk a lot about this, just to say that throughout these 2-part seminars, we will be going into specifics of each condition and their classification. So that's a very quick overview of introduction, embryogenesis, and classification. And with that, we shall start this symposium proper. Thank you very much.
Thank you, Mr. Lam. Thank you for the presentation. Welcome everybody to this Symposium on Congenital Hand Deformities.
This team are an excellent surgical team, and we've had a lot of fun working with them. So thank you, Romesh and your team, and thank you, BFIRST, for all your support.
Thank you very much, Brent. We're gonna conduct our first poll now. So Emma, if you can bring up the first poll. So this poll is about skin grafts. Now, you don't always use skin grafts, but if you do use skin grafts, where would you take it from? So can everybody participate? Just a reminder to please send in your questions to the panel for discussion via the Q&A function. Okay, so you can see that the majority would like to take their skin graft from the groin, and in second place is wrist and then upper arm. Thank you. So it gives me great pleasure to introduce our next speaker, who really needs no introduction at all. He is none other than Professor Scott Cosin. Scott, it's great to have you with us. Scott is the Chief of Staff for Shriners Hospital for Children in Philadelphia. He is also the current team leader for Touching Hands, which is the official outreach arm of the ASSH. He is past president of the ASSH. He was involved in the world's first bilateral hand transplant in a child. Fascinating case. Dr. Cosin is a well-known speaker and author in great demand all over the world. We are so glad to have you with us, Scott, to come and tell us about thumb index and dactyly. Thank you. Scott, you're muted.
About that. Is that better, Wee?
Yeah, that's better. Thanks.
Okay. Thank you very much. And good morning from the United States of America. And I wish the 350 participants on the call safety during this complicated times. So we asked me to give a talk on thumb index and dactyly. And what I thought I would do is expand the talk a little bit to plain thumb index narrowing, because you see it in syndactyly and you see it in other entities. The take-home points is the first web space is critical. We don't realize how much we use our first web space. We need adequate breadth and adequate strength for object acquisition and for holding objects. So in general, a narrow first web space is not very good for function. In general, a thumb that's in the palm is not very good for function. So the goal is going to be, how do we address the narrowed first web space with syndactyly and other etiologies? And we see narrow first web spaces in a lot of different entities in congenital hand surgery. Clearly, syndactyly, hypoplastic thumbs often have a narrow thumb index web space. APERS, that was just elegantly mentioned, arthrogryposis, and cleft hand. And what I thought I would do today is just talk about degrees of narrowing from mild to moderate to severe. And again, these apply to all our congenital differences that we see. And I'd like to spend some time talking about how we address the mild, how we address the moderate, and how we address the severe narrowing or absent of the thumb index web space. So mild we see in Symbrachydactyly, hypoplastic thumbs, and amniotic bands, as you see here. So the slide on the left is a picture of a child with Poland's with a classic Symbrachydactyly hand, and obviously the slide on the right is the amniotic disruption sequence or amniotic bands. And the bands can simply be separated to open up the thumb index web space. So moving on to mild, I'm going to talk a little bit just about the relative syndactyly and hypoplastic thumb. So a type 2 hypoplastic thumb will have a thenar deficiency that will reconstruct with a tendon transfer. The ulnar collateral ligament will require reconstruction, but the main purpose of this talk is to talk about the narrow first web space. So for mild syndactyly or for mild thumb index web space narrowing, we can simply manifest and lengthen the skin by a 4-flap Z-plasty. We prefer a 4-flap because it leads to a rounded contour. We prefer a 4-flap because it increases the distance about 150%. But we teach our residents and fellows that it's not just the skin. You need to address the underlying fascia, both dorsal and volar, and you need to make sure that you identify and protect the princess pollicis. But a 4-flap Z-plasty is our workhorse for a mild syndactyly or a mild narrowing of the thumb index web space. And you can see in this long-term follow-up example, the child underwent a 4-flap Z-plasty and also a tendon transfer, and they've marked an increase in their breadth between their thumb and their index, and now they can acquire fairly large objects. So moving into moderate severe, as was just mentioned in APERS thumb, I think the thumb is so critical for function that we really focus our attention on obtaining a thumb and attaining a mobile small finger in APERS hands. We have really become fans of the Abdul-Ghani flap, and if you are not familiar with the Abdul-Ghani flap, I would give it a go. It's a modification of the original Buck-Gramco flap, but it's a more reliable random flap just by an extension into a rectangular configuration. So I'm going to show you an example. Here's an Abdul-Ghani flap and a complete syndactyly between the thumb and index finger. So if you recall, the Buck-Gramco was a rounded type flap, and now Abdul-Ghani has extended it in this rectangular configuration. Now that simple modification has led to a more reliable flap without loss of the flap between the thumb and index finger after separation. And then, as Brand just mentioned, you see this distal separation in a zigzag fashion, the flaps that are interdigitating, mirrored and opposite, both volar and dorsal. And here is the separation. Again, we try and drive this Abdul-Ghani flap as proximal as possible. So we don't always make our proximal dissection until we're ensured that the flap can be driven as far as proximal. What limits you is obviously your princess pollicis artery, and what limits you is just your flap. And if you need additional skin graft, as you can see on the slide on the right, you can add skin graft. Our preferred site is the volar wrist crease. And here's the follow-up. And if you look carefully at the follow-up, this child needed a little bit extra touch-up. They needed more rotation of the thumb, which was done as a second stage. Now, what about a severe narrowing of the thumb index web space? And you see this primarily in cleft hand. So what you can see is there's a large cleft in the mid portion of the hand, and there's marked narrowing in the cleft hand. I think what happens in cleft hand, a lot of times this does not get addressed appropriately, meaning if you don't open the thumb index web space wide enough, the child will then still prefer to prehension between the index and the ring finger, and they'll subsequently widen any reconstruction. Our preferred technique is really the Snow-Littler reconstruction. There are some modifications of the Snow-Littler, again described by Abdul-Ghani, but this is still our preferred. So it begins with this randomish flap between the index and ring finger. If you can pick up an artery, as you'll see in this case, then this random flap becomes an axial flap, and it's much more reliable, and you get much less epidermolysis. And then there's a Barsky flap on the side of the ring finger, which is used to create a nice commissure between the subsequent index and ring finger. And then there's a straight incision between the thumb and index. The flap is raised from dorsal to volar, And as you come around volar, look for an artery, because again, it changes this random flap into an axial flap, which is much more reliable. We tend to either move the index into the long finger if there's a remnant of the long finger, or perform a basilar closing wedge of the metacarpal to realign the index with the ring finger. You need to make sure that you don't have scissoring. Once that is done, then the flap is rotated into the thumb index web space, and you can see adequate breadth and reconstruction of the thumb index web space. And more importantly, it's clinical follow-up. So here, this child used to grab everything between the index and the ring finger, and now they're using their first web space as a preferred mode of prehension, and that's a home run as far as I'm concerned. Now moving on, there's other cases that we see with moderate to severe syndactyly or narrowing of the thumb index web space. And these are principally children with arthrogryposis. And these can be very, very difficult. It's a little bit different. So you need to look at the arthrogryposis hand and decide whether there's syndactyly between the thumb and the index web space, creating coronal deficiency of skin, or whether there's also a deficiency of volar skin and you need to rotate the thumb out of the palm. As I said in the beginning of the talk, a thumb in the palm is just not a good thing. You need to get the thumb out of the palm. Our preferred technique is either a Ghani flap, or we'll do this stiletto flap, which is an index rotational flap. And then if it's severe, if the thumb is really within the palm, a concomitant MCP joint chondrodesis is performed. Here is your classic index rotational flap, or stiletto flap. So you can see it extends past the PIP joint on the index finger. The defect gets closed primarily, and then all that skin gets rotated under the thumb to provide reconstruction of the skin in the sagittal plane. And here's marked improvement. So you can see the defect is closed, the skin is rotated in, and the thumb is in a much better position. There was a concomitant dermodesis done about the IP joint in this particular case. And then the last type of narrowed thumb index web space is really when there is no thumb index web space. And as we mentioned earlier, this is a defect of the ZPA in mirror hand. You can see it in a 5-fingered hand, or you can see in a type 5 thumb hypoplasia with a complete absence of the thumb. Again, I need to reiterate that the most important part of this reconstruction is to create a thumb and create an adequate thumb index web space or resolution of any narrowing. The treatment is some form of pollinization. This particular patient, the 2 radial digits were removed, and then the next digit was then subsequently rotated into the thumb position. But what's most important is this thumb index web space. And you can see how wide it is, which will be great for object acquisition. And you can see how nice it will add for a mobile thumb. And what's great about being in practice so long is you see patients forever. And here is her long-term outcome. This is 10 or 15 years after pollinization and widening of the web space. What's important to look at is the marked improvement in the thumb index web space, which allows object acquisition and a mobile thumb. And that is just a home run or a goal, as you see here. With that, thank you very much, Wayne, and thank you for inviting me to this symposium.
Thank you, Professor Kozin, for this great presentation. We will now conduct our second poll. Can we have the poll, Emma? So this second poll is about skin grafts. For a complete third web syndactyly, how often do you use skin grafts? Can we have the answers? So our participants stated that 100%, 29% of participants will use skin graft 100% of time, and the next 25% of participants will use skin grafts in 25% of the time, and 20% will use it 75% of the time. Thank you. We will now welcome Mr. Paul MacArthur. Mr. Paul MacArthur is a consultant hand and plastic surgeon at the Mersey Regional Plastic Surgery Unit based at Winston Hospital in Liverpool and at Elder Hay Children's Hospital. He was a visiting professor at the Wake Forest University Department in North Carolina, and he travels to Kenya as part of BFIRST, and has special interests in congenital hand spasticity and pediatric plexus injuries. He will be talking to us about the graftless techniques on syndactyly. Mr. MacArthur, please.
Hi, I hope you can hear me.
Yes, we can.
Hi, thank you. Thank you for those kind words of introduction. As mentioned, my part in this webinar is to discuss or to demonstrate the techniques that I've developed with my colleagues at Alder Hey over the past 15 years to hopefully avoid the use of skin graft techniques. And my visits to Kenya really brought home to me how privileged I am to work in an environment in the UK that has the infrastructure to allow development of techniques, but also not to have to think too carefully about conditions such as climate that may affect dressings and also ease of access to resource. So I'll touch on a couple of those points towards the end. But I was encouraged to see from the poll that's just been conducted that quite a few participants today are actually using skin graft-less techniques. So I will show through the course of the next 10 minutes or so how I would go about doing this. As Sarah Tucker said at the beginning of this seminar, this is not about whether or not our techniques are the only techniques. They, of course, form part of a wide variety of methods to manage complex problems. And so I offer this to add to your list of options in managing syndactyly. So the techniques I'm going to talk about are, broadly speaking, the stingray flap and the islanded web transfer for managing all aspects of
Paul, you have to put, sorry, Paul, you have to put your thing on slideshow and move the...
Oh. Okay, are we...
Nope, it's still not on slideshow.
Paul, if you click slideshow at the top, it should give you an option to play.
Yeah, that's what we're doing. We're running here.
Oh, there we go, perfect.
Oh yeah, okay.
Yes.
Okay, so we'll go back, okay. So apologies for that. So my brief today was to talk about skin graftless techniques, and I'll demonstrate a couple of techniques that we've developed at Alder Hey, which, like many techniques that have been developed over the years, touch on what's gone before using the principles set out by Bram Simvanakumar, and I'm very grateful to him for covering many of the points that need to be addressed before entering into the surgical area. So the stingray flap, we coined the phrase mainly because of the size and shape of the flap, the orientation, and a certain amount of inspiration taken from this image from an aquarium in Dubai. The skin markings are as demonstrated here on the left. The green lines indicate the midline, and perhaps what is slightly different about this technique is that I would encourage people to go beyond the midline of each digit in creating the wing of the flap, as you see here. This allows for easier closure, but it also might raise the question of what do you do if you have 3 digits? The honest answer to that is, in the closure of this flap, as we see on the picture on the right, dorsally, there is an incised scar that develops, and that this can form the base of the flap to the adjacent web if required. The modification that came into play with this technique was to split the distal part of the flap to create, as I'll refer to, the mouth, if you like, of the stingray. The purpose of this is to interdigitate with a small volar flap that you can see on the right as we look down into the web from distal to proximal. And as was beautifully demonstrated in the previous talk, the Buck-Gramco flap or stiletto flap for the tip of the finger can be incorporated into a complete syndactyly if you are required to reconstruct the medial or the nail folds. The key, however, to closure with this is, as you can see in the top left-hand corner, a cross-section diagram that I've put together indicating the excess fat that we see in the space below the flap. There are many pictures in the books that talk about the geometry of skin and the lack of skin to close this area, but there is very little talked about this, this fat, and it is key, in my opinion, to achieving closure that this fat is removed. That always causes a little bit of concern to trainees or to observers who take the time to look over the shoulder, because of course in defatting you may cause thinning of the finger, which has not been demonstrated in my 15 years of doing this. But what we have noticed is, as one can see, this green area between the neurovascular bundles in the syndactyly fingers, a sheet of fibrous tissue, which is part of the failure of separation of the fingers. And it is my view that this fascial layer goes on in the normal finger to form Clellan's and Grayson's ligaments. This is actually a useful landmark when defatting from posterior, as it protects you going into and onto the vessels. So to look at an operative series to demonstrate how we go about, this will look very familiar to most people. We have a case of a third web complete syndactyly with a mild simple incomplete on the third web for those, sorry, fourth web, I beg your pardon, for those with a keen eye. The volar flaps are drawn in a very similar way with zigzags along the finger, as we've already seen. But you can note the small V-shaped flap on the palm, as we see here, that will interdigitate with the mouth of the stingray flap. And as you can see, that we've extended the wing of the flap across the midline to allow us to recruit more tissue into the web. And as pointed out earlier, the Buck-Gramco flaps are sitting in here. So the stingray flap is raised in a very thin fashion, almost at a dermal level. The pocket of fat, as we can see here, is removed to the point that one can expose, if needed, the paratenon of the extensor mechanism. And here we have the flap of, the volume of fat. The web is then recreated using the wings of the flap, which come onto the side of the fingers, and the mouth sits into the interdigitation. As we can see here, the donor sites are closed directly. You do recruit, to some extent, skin over the metacarpal phalangeal joints in order to facilitate this, but closure is achievable fairly, and I say in this case, fairly easily. And you'll note the Buck-Gramco flap sitting distally in here. Now, if I just go back a slide, the key point in closure, in my experience, is the insetting of the mouth into the palmar flap as the first step. I would then proceed distally to proximally, closing the wound with a continuous suture, as one may see here, of very small bites on the tissue in order not to incorporate too much tension. One can see a mild degree of blanching in this finger, but as always, we have seen perfusion of the fingers, and we've not had any problems with loss or necrosis. As mentioned in the previous talks, surgery is usually carried out at approximately a year to 12 months, year to 2 years of age. Often that is influenced by function. Operations will be carried out earlier, as mentioned by Mr. Sivakumar. But the volume of fat that we have excised in a recent study has been, appears to be on paper, quite a small volume of 0.4 to 1 milliliter. It does make a big difference. And so one or two other situations, we can see a more complex syndactyly in the little finger and ring finger. This child also had an accessory digit. Graftless technique was used, excuse me, and this is the child at 2 years post-operatively. We can see a slight deformity of the finger, but if one notices, there was a skeletal difference in this case. Once again, similar techniques used with good scars, inconspicuous. The skeletal anomaly has led to a slight deviation at the tip of the finger, but functionally this child works very well and has not required any further treatment. One or two more cases just to demonstrate the quality of the scarring is inconspicuous. We don't have the issues as I had seen in my predecessor's caseload of pigmentation of skin grafts or hair growing from those. So in conclusion, with the stingray flap, small volumes of fat can make a big difference. We can close often complete simple syndactyles without the need for skin graft. And there's been no thinning of fingers observed in 15 years, which was a feature that was always put forward by my predecessors and the generation before. So there's long-term disadvantages of skin graft, as we've already heard. I'll move on quickly on this, as we see here. And I'll move on to the island flap. The island flap was published in the Journal of Hand Surgery, which is demonstrated above. Now, the island flap is useful in simple incomplete syndactyles up to the level of the PIP joint. And in effect, as we can see drawn here, we have a dorsal view whereby small vessels do come into this area. The extent to which you need to move the flap will determine how many of those vessels you are able to preserve. Obviously, you need to keep one. But again, we've had no problems with this technique. The distance in terms of markings is determined by the distance between the web of the simple incomplete syndactyly and the position of the web that you need to reverse it into. This is X on the diagram on the left. This brings about the decision or the distance to mobilize the flap proximally. The flap is elevated with a small modification. As you'll see, we've introduced the mouth principle with a volar flap to inset. The vessels clearly need to be identified, and on occasions, as we've all no doubt discovered, a distal bifurcation of the digital nerves can be managed with careful interfascicular dissections. The inset of the flap is shown on the right-hand side. Just a short demonstration. This is a 14-year-old golfer who was having difficulty wearing his golf glove and had been put forward for professional the professional circuits. As you'll notice, the keen-eyed of you once again, that he doesn't have a palmar flap as he was done pre-modification. So here we demonstrate the flap dissected with the small vessel indicated by the arrow in the picture. The flap is elevated, mobilized, and one can see the spread that the fingers are able to obtain. And here we have the flap inset, once again with small, continuous, fine, dissolvable sutures. And here he is 2 years later. So the tips to closure, to summarize really, I see that we have a talk on Wallant surgery later, which is no doubt extremely useful in certain circumstances. However, my experience through training of putting local anesthetic into fingers causes tissue swelling, which makes closure of these meticulous areas somewhat difficult. I would therefore advise against putting local anesthetic volume in the fingers themselves and use a more proximal infiltration method around the wrist or in the palm and dorsum. Careful planning is always a tenet of plastic surgery. And we saw from Mr. Sivakumar's methods of using the drapes, which is an excellent idea not to get confused. But please remove the fat. It will facilitate the closure of these wounds. It will facilitate the closure of the mouth, as mentioned before, first, and then to work distal to proximal with a continuous suture using small intervals and close to the incised edges. The continuous sutures I use dissolvable monocryl 5-0. I'm sure there are other appropriate sutures available in different parts of the world. I've avoided using Vicryl because of potential infection risk on a braided suture, and it doesn't seem to hold quite as well as monocryl in my hands. The dressings are key. I've learned from my experience in Kenya that to rethink how I do my wounds. And I now move towards sealing the wounds with histoacryl glue or tissue glue as a dressing to avoid the wounds coming into contact if the dressings slip. And this has proved very useful. We're gathering information and hopefully we will present on that at some point in the future. Again, in my experience, in my environment, in my climate, we are able to use Mepitel, gauze, wool and crepe. I don't use plaster of Paris. And ideally, if you are able to, and if your patients are able to, leave the dressings in situ for 2 weeks, at which time the vast majority of these wounds are healed. So the key points, we have a high number of in our center. We've used 95% of this technique in 95% cases. We've had no donor site morbidity, primarily because we don't have a donor site, and we don't have the problems with full thickness skin grafts. And just to show some of the problems, these are pictures which I'm grateful from my visits in Kenya. One can see the hypertrophic scar from a donor site on the left-hand side of this child. The syndactyly release has worked extremely well by the operating surgeon before me, but I've been able to demonstrate the use of a stingray flap and an island flap in the 2nd and 4th web space with, I'm reported by my colleagues there, the child is doing very well. It's not just simple syndactylies. We're able to use the techniques in complex Apert syndrome. This young man came to me at birth and he was delighted. His mother was delighted when he placed these 5 hula hoops on his hand, as he is now a 5-digit child without the use of skin grafts. Thank you for your time, and thank you to BFIRST and the BSSH for giving me the opportunity to share this technique. Thank you.
Thank you very much, Paul. Excellent talk. We're going to move on to our last speaker now. And he is, again, a speaker who requires no introduction. He's well known to all of us. He is Professor Raja Sabapathy, who is the chairman of the Department of Plastic Surgery at the world-renowned Ganga Hospital in India, past president of the Indian Hand Society, Indian Society for Reconstructive Microsurgery, and Brachial Plexus Group. Raja, thank you very much for coming to speak to us about how to avoid and manage complications.
Yeah, thanks, Wei, for this opportunity. One second. Yeah, the question is how to avoid complications. If anyone has listened to the first 3 lectures and they exactly do what they say, I think you will avoid the complications. And it's very important to avoid complications, particularly in a country like India, because simple syndactyly, if you don't do anything, they don't have a functional deficit. But then if you have a complication, usually it downgrades function, and that's exactly not acceptable. And how to avoid is plan well. And in our setting, we find that we do have used Graftless technique, and that's for an expert. I think if you are starting, and many times now you will require grafts, and I'll come to that, that's true. If you ask for complications, the most dreaded complication is digital necrosis. I think there's some small tip part of it may necrose, and it could be partial too. It's very, very rare, but that's the most dreaded complication. It can happen if the separation of the central digits, and when you have 3 or 4 syndactylies, so that's the reason say don't separate syndactylies on both sides at the same time. And when you do that, I think what we do, even here it doesn't occur. Very rare to have this complication. I think only one thing they say, if they have one vessel, the question is to which side do you have to leave it. What we do have to do is, see, suppose it's a single vessel, you leave it on the side of the central digit. Suppose you are separating this, leave it on this side. So that the border digits will always have blood, so the marginal digits will always survive. So if you have to leave a blood vessel, leave it on the other side, so that in case when you separate embed in the fingers, and you don't have to worry at all, because definitely there's at least one finger, this thing is just left. And during simple syndactyly separation, if at the end of surgery, the fingertips look pale, then release some sutures. I think don't think it will get better and then leave them off. If you're not able to follow them, I think some of them will necrose, some tips are necrose. I think what it really requires is to remove the sutures. Maybe now it may require a little bit of graft. So that's very important. The next is the problem of web creep. I think this is the commonest complication that we have. I think necrosis is very rare. So what's web creep? Is a distal migration of the web, so that it appears as if there's a partial recurrence of the deformity. If you get a result like this, it's good. And I just borrowed this from the Peter Waters book. I always use skin graft. And the next thing that we use is you have a big flap into the web. I think when you do a syndactyly, you must have a flap in the web. I think no matter what you choose, I think you choose any technique you like, graft technique, graftless technique, but you need to have a good flap in the web, which is a viable flap, and then you will not have it. And deviation and contraction of the fingers. And what we tell our people is don't try too hard to avoid grafts. I think you will not face this problem. As a beginner, I used grafts. And when I consistently got good results, I think we are reluctant to change and continue to use grafts. But then if you use grafts, I think a lot of people use grafts in India and in many of the developing countries. They don't use a full thickness. They always, sometimes they go on to a split thickness. I think that's no. Either use a graftless technique or use a full thickness graft. And when you're harvesting a full thickness, you need to be very careful so that you don't get hair. And I always now mark the size of the grafts and number them, and then put them numbers like this. How do you take it so that you make it quicker? And then when you incise them, you incise the margins deeply and makes a lot of small scratches here. And then harvest the whole thing. I think that's the way to harvest, so that harvesting is easy, so that you don't really miss, you don't really lose grafts. A bad outcome, I will show you a bad outcome. So this is a bad outcome. And what you really need to have, I think I will get back to that same child, see. The graft must take well. If they don't take well, that means now you need to graft them. Suppose if you allow them to heal by secondary intention, with few dressings, the children heal very easily, I think raw area, and then rapidly can narrow it. And then as the child grows, it goes to a very bad deviation. See, we have done a graft, and then see, you look here, 2 weeks. So we look at it 2 weeks. I think 2 weeks, it must be nice. The graft must have taken well. The rare occasion when it's not taken, that means you need to regraft with the thickness graft, you need to put it. But then if you allow it to heal, if you just give it a couple of weeks, it'll heal. But then they come, if you see them after a couple of years, then you'll find this problem. So the moral of the story is, if at the end of 2 weeks you lost the graft it again. The timing of surgery, we find the complications are higher if you graft them, if you separate the syndactyly very early. That's because when you do it very early, the flaps are smaller. Or if you have to graft it, the grafts are the area is very small, and you really don't know whether you have lost a big area. Even if a small area, the graft is lost, you will find it's supposed to be very insignificant, but then it becomes very significant when the child grows. So the goal is that you need to get all the raw areas healed primarily. And the post-op care is very important. I think one of the simple ways of doing how we prevent the web creep is we roll the 3M tape. You make a complete roll of the 3M tape and then put a bulky roll, and that's available everywhere. And then I put it in the web and then put another tape on this. We give every patient a one roll of 3M tape. I think it works very well. Of course, the silicone gel sheets, all these things are there, but then this one works very well. It's very cheap, and then it's available. And even in tropical countries, it's very good. The nameplate deformities, I think a lot of it has been, the Buck-Ramkos flap has been alluded to in quite a few times. But the most important is when you do this, the flap just has to cost, I think almost beyond the midline it has to cost. Only beyond the midline, and it has to be a good flap. It cannot be a very thin flap, and it has to be a good flap so that it covers on the side. And at the end of it, when you separate it, it must look like this. I think because you must have this much of the flap has been there, so it must look like that. And make a full plan in complex syndactyly is always take an X-ray. Sometimes people don't take an X-ray and then lay it on. And when you speak to the parents, because when you operate a child, you're not operating a child, you're operating the parents. And if you have a problem with the X-ray, suppose you must not fail to detect this delta phalanx. So if after the separation, that phalanx, that finger will be bent, I think you need to be aware of it before. So you need to talk to them about it. See, it will get there, but then you'll find that there is a small amount of bend that will get, and which you need to correct it at a later stage. And sometimes in syndactyly, beware of buried skin. I think they might have inside the buried skin causing infection. So they come up and they find cellulitis. Then you find here a sort of a cyst that is going on here. I think a dermal cyst that is there, and that you should be very careful. Do not worry about multiple stages needed in multiple syndactyly. I think don't try to overdo, but then you must do each stage very well. Small compromises you make in each stage will lead on to a much bigger compromises in the outcome. For example, this is a child who has got that's the right hand, and that's the left hand. So you need a thumb, you need to separate all this syndactyly. So that's the result that we got after separation of the syndactyly and polycization of both sides. I think, but then you find each side when it's separated, we sorted that the wounds have healed well, and that's the same child now operating with the left hand and using the right hand also. He is on very well. So we are coming from this stage to here, and we are come from here to here. So only thing is that the most important is each stage you do it now very well. So that's a 10-year follow-up of this child. So child is able to do all her activities, able to pinch and do all activities. So to conclude, before that, there's one more. You don't overdo. I think this is also alluded to before. See, a child comes like this, and it's very important the thumb comes out. I think it has to come out now very early. So the thumb comes out. But once the thumb comes out, see, that's how you got. But then don't try to separate these fingers. I think they will not do very well. See, I think what you really require is this acts to hold up bigger objects. And when they need to have a pinch, they use the thumb and the little finger that they will pinch. If you try to separate them, that means functionally they will become bad. So the moral of the story is don't overdo. So to conclude, what we require is you need to plan properly. Whatever technique that you use, in 2 weeks, the wounds must have healed well. Children, small scars, small areas heal very easily, but then as they grow, they lead on to contractures. If you do a Buck-Ramkos flap, make the flap a good flap so that it's a viable flap, it sits well. And never worry about the number of procedures you do, but then each procedure you do it very well. Thank you so much.
Thank you so much, Raja. So we're gonna have a Q&A session now. We're gonna try our best to answer as many questions as we can. I'm gonna go right into it. It's fascinating to hear the different views, and this was deliberate. Some people favor skin grafts and others don't. So the first question is for Bran. I think there's a question on why do you prefer a triangular flap rather than a rectangular flap, and do you have problems with the flap contracting?
So the reason I use that, as we've talked about, I think all the speakers have mentioned, there are a lot of options, and I think that the most important thing is to do the procedure very carefully and to raise the flaps very carefully. The reason I use the interdigitating triangles is because when looking from the dorsum of the hand, there's no minimal scarring on the top of the fingers, and you see that nice sweep of the larger triangle on the top dipping down into the web space. And because you've got these two triangles, they can slide against each other. So if you have a slightly distal bifurcation where you can't ligate one of the vessels, it gives you the opportunity, if you had to go tip to tip, or slide them until you can comfortably get over the arterial separation. And I've had pretty good results with that. Having said that, I've seen good results with all the different flaps, and the Stingray flap looks very good. But the key is to use that local tissue, raise it correctly, and be absolutely meticulous with how you inset it and handle the tissue.
Great, thank you. Question for Scott. It's a question about the mirror hand. Fascinating case. Do you always remove the radial digits?
So it's a great question. So the answer is no. So what we rely upon is the most mobile radial digit gets policized. So it's not always the most radial. So you have to incorporate your therapist's opinion and watch the child and see how they function. But whatever is the most mobile digit becomes the thumb.
Great, thanks. I'm going to move on to Paul about the Stingray flap. This is from Teddy from Indonesia. The Stingray flap is great, but would it be difficult for the small baby, the baby that's less than 6 months old?
Can you hear me?
Yes.
I was often told by my teachers in the past that if it's small, just turn your loops up. So the key to this is the technique, and it's been reiterated by others. The key to this is careful planning and careful dissection. And often the limitation in a child of less than 6 months old is not the surgical limitation, it's the anesthetic limitation. And yes, we have done the surgery in smaller hands than 6 months old, but actually what we're looking at the moment is that we find that the younger the child, the more likely they may have a scar contracture or a web creep later in life requiring a revision. So yes, it can be done in the smaller hand. It just needs a little bit more care.
Thank you, Paul. So a question for Raja. If you have a case of bilateral syndactyly, do you do one side at one time or both hands together?
No, I always do one side at a time. No, so I never do both sides at a time, so that we, in case of the very rare occasion, get a problem. So you shouldn't do that one. And secondly, it does take time to do syndactyly. So I would prefer to do one side at a time. And children also become a little more cranky if both sides are in a bandage.
That's interesting. So let me just open this up a bit. Bran, what do you think? Would you do both sides together or one side at a time?
I find, particularly having treated quite a lot of syndromic syndactylies where you have to do multiple stages, try to minimize the number of procedures. Under about 14 months of age, children will tolerate having both hands in bandages quite well. As they get a little bit older than that, I think they get quite frustrated. They're very adaptable, but I tend to, with the older kids, stage it. So I'll try and get the majority of those separations done one hand at a time. So I'll do one hand, bring them back 2 weeks later, change the dressing on that hand, do the other hand at the same time. And then 2 weeks after that, come back and do the change of dressing on both sides. So you can combine as much as possible.
Great, thanks, Bran. Scott, what do you do?
So we do both sides at one time, and primarily because I have a very talented partner Dan's-Latelos. So we'll do both sides. It's a little bit harder on the babies. So we tend to put one arm on an arm board and one arm on the OR table itself. And then the person that's operating the table kind of spreads their legs to get into the arm. But we prefer to do both sides from an anesthetic, number of anesthetic times.
Great. Paul?
Well, I've been a firm believer in one hand at a time for reasons of the younger children putting their hands and bandages in their mouth, risk of infection and so on, although I have to say we haven't had those problems. But I agree, we stage it, we do one side, we may do, for example, in an APERS child, we'll do second and fourth web space on the left, we may then go to the right to do the second and fourth, and then we'll come back and do the third web. We do that slightly differently, of course. If the thumb's involved, we'll do first and third first, and we'll switch to second and fourth later. But yes, as a general principle, we work one hand at a time, and I have an extremely experienced and fantastic hand surgery sister who I'm pleased to say we've not needed to put the children to sleep for any dressing changes, and so that allows for a little bit more planning and a reduction in the anesthetic time for the children.
Thanks, Paul. We're going to move on, actually. I mean, there's still quite a few questions on syndactyly. I'm going to invite the panel to just type your answers if you can, so they will be answered, but we are running slightly behind, not too bad. But we're going to move on to our session on macrodactyly. I want to introduce the two chairs. One of them is Bren, whom we have already heard his talk. He is a consultant from Great Military Hospital, currently in Doha. And the other co-chair is Huyen Tran. I have the delight of meeting Huyen in Vietnam. She is a consultant plastic surgeon at the Viet Duc Hospital in Hanoi. She has been in practice for 15 years. She was a BFIRST fellow, Synthase fellow. We're very glad to have Huyen and Bren chair this session. So I'll hand over to you guys now.
Thanks, Wee. So macrodactyly, it's a very challenging problem, something that's both functionally debilitating and can be cosmetically very upsetting for children and their families. Whenever I'm on a panel or I'm asked for advice regarding a case, I can guarantee that there'll be a macrodactyly case within that mix. Often it's not as straightforward as amputation, particularly if the thumb is involved. So very excited to hear this next session, and we're honored to have Professor Scott Cozen start the session off with the principle, so I'll hand over to him first.
Thank you very much. Let me just share my screen. Bren, do you see my screen or no?
No, Scott, I think you got to share the PowerPoint bit.
Give me 1 second.
It's in your desktop.
Yep, it's coming. How about now?
Great,
Yep.
Thanks.
Yep, sorry for that confusion. So I'm going to introduce the section, talk about macrodactyly principles of management. And as Bren said, these are very difficult children to treat, and they are really, really challenging for the best of the best congenital hand surgeons and vascular surgeons. I do have a few take-home points, and we've learned this over the years. It used to be this hodgepodge of different entities, but they're all part of the pica-related overgrowth spectrum. It's rare and it's difficult to treat, but this has consolidated the concept of macrodactyly, at least for me, into this entire overgrowth spectrum, and it's made it more clear from an understanding standpoint. But it can affect the fingers, the hand, or the limb. But the dysregulation, this is what we spoke about before, is post-zygotic. So it's a gain in function mutation in this pica, a component of the mTOR pathway. So I'm going to show you a very complicated slide, but the point of the slide is if you look at the overgrowth spectrum syndromes on the left, whether it be macrodactyly, fibroadipose overgrowth, muscle hemihypertrophy, which we'll talk about, cloves, all these entities are all related to the same signaling pathway. And if you look on the right side of the screen, you see more syndromes that we used to consider separate entities, and now they're all related, like Proteus, like the megacephaly. All these are now related, and they've all been shown to be part of the signaling pathway. Now, why is this so important? It means that one day there may be some type of pharmacological solution to this problem. And there's lots of stuff being performed in a limited basis for some of the very, very bad overgrowth syndromes like Proteus that are very, very disfiguring. So this gives us promise for the future, as I was taught by my mentor, that this is probably a biologic problem that we treat with a surgical solution, and that leads to poor outcomes, right? And the other thing that's happened, to make it more clear, at least in my brain, is it's tissue specific. So this slide is really important. So the tissues you see on the left, if it's pleiotropic, it involves all the tissues, like clothes. If it's tissue specific, it may just involve the muscle, like you see in the muscle hemihypertrophy on the left. And then there's different phenotypes, just like everything else. So this makes it clear to me about we're treating the same type of entity. It's just a different post-zygotic mutation and a different phenotype severity and a different tissue specific. So that's cleared it up a lot. So things now like Klippel-Trenaunte-Weber, like you see here in this, are all part of this pike-related overgrowth syndromes, as is hemihypertrophy. So 20 years ago, we used to see this entity and not actually know what it was. But if you have hypertrophy of the intrinsic muscles in the hand, you end up with these deformities, which are attributed to the pica-related overgrowth syndromes. Now, some of them are incredibly disfiguring, and some of them are daunting and haunting at the same time. And when you see a child like this, who's severely affected with with bilateral arms, and his brother's affected, it's really a daunting surgical task. So can you imagine how much pain it is to the family to have children who are affected by this grotesque hypertrophy of both limbs here? And macrodactyly is a lesser degree of the pica-related overgrowth syndromes. So we're going to focus on macrodactyly, but understand that it's all part of the same phenotype along the way of this pica-related overgrowth syndrome. For us, or for everyone, it's the most common form of macrodactyly is related to the lipofibral hamartoma of the proximal nerve. So when it affects the median nerve is enlarged. When it affects the ulnar nerve is enlarged. There's lots of controversy when you're operating on macrodactyly of the median nerve innervated structures, whether you should do a prophylactic release of the carpal tunnel. We tend to do it and look for the lipofibral hamartoma of the median nerve, because children will have asymptomatic carpal tunnel and they'll present with wasting of their thenar muscles. They don't complain of sensory loss and they don't complain of motor loss, and then you've missed an opportunity. So we tend to perform a carpal tunnel syndrome when we operate on our macrodactyly. Now, it's usually noted within the first years of life, and from an orthopedic hand standpoint, there's two different types. The growth may be disproportionate or progressive, or proportional or static, meaning the digit is always enlarged, but it grows proportionally with the other digits. And these are the one where I think salvage is possible. The progressive is extremely hard to treat. So with reference to static, the basic principal tenets are you want to try and preserve the digit, obviously, especially if it's a thumb. You want to do multiple debulkings. We still perform half the finger at a time. When the finger is the same size as the same sex parent, you want to stop the growth via mid-lateral approach. The problem with that is oppositional growth continues, and often as these kids get older, the fingers become somewhat stiff. The digital shortening procedures, and I'd love to know what the panel thinks, these have been frustrating, difficult, and unreliable to me. So you see lots of pictures of the nail being transposed proximally on some of these large digits, or the nail being widened. My results have not been reliable. So I tend to defer these principles unless the parents are really, really pushing it. Now here's an example of a girl with muscular hemihypertrophy who had static macrodactyly of her fingers. So if you look at her hands, it's the right hand that's more affected than the left, although there is widening and splaying of the fingers on both sides. Her hemihypertrophy affected both limbs. You see the x-rays on the right. And we began this arduous process of debulking her right thumb, of limiting the growth of her right thumb, of debulking her index finger, of limiting the growth of her index finger. And this happens over time. And if you stick with it, you can end up with a fairly functional hand. Now, fortunately, she didn't become very stiff. She still maintained this muscular pose. And then here she is, long-term follow-up. And I think that's a win. I mean, it's not a perfect hand, but it's a mobile hand and it's a 5-digit hand. And you can see she's fairly symmetric. So for static macrodactyly, I think we're pretty good at treating it. And we're pretty good at getting the digits of relatively equal size, especially if they maintain some mobility. The hyperostotic macrodactyly, the ones that develop the osteophytes around the joints, become incredibly stiff over time, but we can still maintain the length, although the bulk's always bigger. For progressive macrodactyly, if it's an isolated digit, I truly try to encourage the parents to have early amputation. So if it's a single digit, not the thumb, of course, if it's a single digit, I want to do amputation. Now, sometimes we will do the thumb, and I'll show you a case at the end. Because the question really becomes how many fingers are enough? And this is obviously a patient of mine who's high-fiving Mickey Mouse at Disneyland. And for those that don't know, Mickey only has 4 fingers, and so does my patient. And I always encourage the parents to think about early amputation in progressive macrodactyly, especially of an isolated digit. Here's an example. This is a child from Puerto Rico with an enlarging long finger. It's a little bit hyperostotic and it's become stiff. We encourage the patients to have early amputation. So the finger was moved at the ray and the index finger was moved over and fixed with a plate and screw construct. And then here, you want to make sure, like I said before, under syndactyly talk, you don't want to have any scissoring or malrotation. And here's the closure. And what's important is here's the function. So I think this is kind of one and done surgery. You took a relatively disfiguring digit. You didn't spend countless surgeries and end up with a stiff digit. You removed it, and you end up with a functional hand. So that is my preference for a progressive macrodactyly of a single digit. And here's his function again. A case of progressive macrodactyly involving the thumb and index. This is when our touching hands visited Ethiopia. We'll hear Ethiopia talk later this morning. It's a 2-year-old with progressive deformity. I don't know how to manage this problem of Usman. And Usman is pictured on the left, and that's Richard Gardner, who's an expat who functions at Cure Hospital, and that's Duredi Fufo, my partner in crime in Ethiopia. But look at the size and look at the girth of Usman's hand. I can't think of a surgical way to reconstruct the thumb or a surgical way to preserve the index finger. So this is help. And what we did here is we amputated the thumb and index finger, and we performed a long finger amputation. And we've now done this a half dozen times. It works. It's a little bit of a difficult operation. I'd recommend you do it with a friend like Duredi. And then once you have the operation done, you end up with these large nerves that are cut, and you end up removing this enlarged, grossly enlarged thumb and this grossly enlarged index finger. And then here is the pulsation of the long finger. And it seems to work very well, but as always, sometimes, especially in developing countries or low middle countries, there's some bumps in the road. Usman went home, and then Usman came back with maggots in his cast. Here's debridements from the maggots. Rick Gardner, fortunately, was at Cure Hospital and took care of Usman. And ultimately, there was nice closure, some debridement of the tissue without much difficulty. And here is Usman's attempting function. Here, watch, you'll see open and close here. And that's a pretty good result, actually, I think, with a single operation, although it was complicated by some additional debridement by the maggots. Thank you very much.
Thank you very much, Professor Scott Cousin, for such a excellent topic presentation. Next up, we have poem time for third poem.
Are we doing the next poll?
The question in the practice and experience. Yeah, okay. For this poem, our result shows 45% debooking and 28% for do not have any experience in testing this condition. For the next speaker, we have a pleasure for welcoming back Professor Raza Sabawati for the topic, how to counsel parents and what to do when amputation is refused. Professor Raza is a very special guest from India. Please, Raja.
Raja, you're muted. Sorry, Raja, you're muted. Yeah,
Raja?
we can hear you now.
Yeah. Yes. So I like the statement of Adrian Flatt. You know, he said Macrodactyly dwarfs the giants of hand surgery. So not only giants, you know, anybody can dwarf. The reason for the statement is if you attempt macrodactyly correction, you're destined to do multiple stages. That's one. And secondly, complications are higher. Because I read somewhere that in a macrodactyly, all the tissues, the tendons, the bones, the fat, all of them may be more. But then the size of the distal vessels is almost the same as that of a normal vessel, many times. So when you do flaps in macrodactyly, the flap necrosis is higher. They are relatively underperfused. So you need to be careful about that when you raise flaps in macrodactyly. The end results are not always satisfactory. And so for that reason, we always suggest amputation early in life. I think perhaps that's the best option. They have got a variable presentation. I can come like the small fingers, and then they may become like giant fingers like this. I think that's where the problem comes, because they are a big spectrum of cases. I personally find when the parents bring the children, the decision is very easy, and they also agree. If it happens in the index finger, it's a single finger, then the ray amputation is the choice. I personally don't offer them other choices. But when it happens in the central finger, particularly if it happens in two fingers, then it's a problem. I think then if you do a ray amputation, if you amputate 2 fingers, then it will leave a small palm. So that's there. So if you are going to offer them reconstruction, that means I have this as a goal. That means if you offer them reconstruction, the ultimate functional result should be better than amputation, and that it should be achieved with as little morbidity as possible. So the aim of the surgical procedures, I start with the small one and then go to the bigger ones. You need to have a 3-dimensional reduction in length, breadth, and volume. And usually their angulation is present, that needs to be corrected. And if the PEP joint is present, that means you need to preserve the range of movement. I have found in macrodactyly, you cannot create movement, but only what you can do is if there is a movement that's present, by your surgery, it can stop. I think that's what you need to avoid. And you need to keep some nail at the end of the finger. Suppose you amputate and then give them a blank stump. That means they don't like it. If you have something like a nail at the end of the finger, it usually gives a completeness of the finger. So we'll start off with this type of macrodactyly. Okay. So here you find before surgery, the child, they are able to flex the PEP joint. So one of the things you need to have is that you must never allow this to go. And you see the X-ray, you know the deviation where it is present in the index finger and the middle finger. So you need 3-dimensional reduction length, breadth, and volume. And you need to correct the angulation. And you need to preserve the range of movement. And if you have the nail, when you reduce it, the nail, you can't have the same size of the nail. Then it looks bad. I think you need to reduce the size of the nail. So how do we do this? Because these parents refuse amputation. Stage 1 is we need debulking. So we do the debulking of the stage 1. First stage, I debulk it. So whenever you are embarking on multiple stages, I find that the first stage you must show some significant result. You need to show them difference. I think that's very important. Only then they can do the next stage. You need to keep happy people, because they are pressing you to keep doing this. Then you need to keep them also happy. So that's the first stage. So the size of it is reduced. I put in simple drains at the end of it. So that's it. So you will find macrodactyly, I think we operate a lot of these so many hand deformities in children. I find that macrodactyly alone, they have higher incidence of forming hypertrophic scar. I don't know why. So still is maintained. And that's the next stage. And this is the most complicated stage. I think this is my drawing at after the operation. So what happens is that's the relative size of the nails that we do. To reduce the three-dimensional, see, I do this. I think you need to make an incision here. You cut the center part of the terminal phalanx is divided. You do it straight away, go in and divide it. And this part of it is osteotomy. I think so. You need to have an arthritis over here. This is it. And then this part of the nail bed is removed because you need to reduce it. And then you have to bring them closer because the bone is gone. You take a stitch or the germinal matrix level. You need to take a stitch and bring them close. So put it in the line drawing. I think that's the way they joined, and then we'll see how it is done. So that's the marking. So this I'll be taking it off. This much of center part of it, I'll take that off first. And then we are doing the osteotomy in the middle. I think the terminal phalanx distal phalanx is divided. The central part of the distal phalanx is divided. So that means that part of the distal phalanx is gone. The articular surface is gone. So this is what is gone now. And next is, if you have a deviation, you would just make some adjustments in the bone as the adjustments that you do, it's an adjustment in the bone. And now it is becoming shorter. And you need to reduce the total length you need to reduce. Because we are taking the central part, this part of the nail is reduced, but then you need to reduce the upper part. So this I reduced it later. Now we reduce this, I reduced, cut it up. And then you fix with one wire. And I think you can't fix both the parts. You can fix one because the distal phalanx is intimately adherent to the nail bed. That part of it which is retained, you shouldn't not disturb. So by suturing the nail bed, you can suture it. So that's it. That's the size of it we get. So that's such a big nail we have got. I think that's the nail. That's the nail we have got. So this has been the length of the nail, and that's the short of the nail that we have got at this stage. And the follow-up at 7 months is this. So the final result that you have is this finger, which has been bent. This has not been bent. And such a huge nail you had a nail, and then they retained the flexibility of the finger. So before you started here, and you end here. So that's the way you end. And you started there, and then you end here. I think that's the radiograph that you end here on a long-term basis. And then you're able to use it. But if you really find how well they use it quite all right if you don't really mess up the PAP joint. And this child has now grown to he's in the medical school now. So now we come to the next bigger problem. So if you have this bigger problem, there again now we have to have some strategy changes, and that's the X-ray. Here again we tell the parents you need to amputate. I think that's the best answer. I send them back. I think again they'll come. I think I send them back, and they will ask me whether if you have got any patients to show, can you show us some pictures whom you have done. I don't show them. I tell them amputation. So if they still persist on, then before starting, then I start showing the pictures and tell them, no, this is the way it has to go at a lot of times. So what we do is, first I take a nail bed graft. See, this is the nail bed graft has been taken. And you need to get the nail. That means now you need to take it up with the germinal matrix also has to be taken, and this is the skin over here. And this needs to be split and put back. That means when you put this cannot get vascularized. So after taking this, you need to deepithelialize this area. I think you need to take up the whole of this. You need to deepithelialize. And then after that, you just straight away we amputate and then close it. And you've got now 2 parts of it you divide. So remember, this is all a major complex procedures, but then it is only for the recalcitrant, persistent parent. Okay, but then we need to give them a good hand. So now, how do we put the nail bed graft? I think this is one of the things, techniques now which we devised. I try to think where the nail should come. So that's the place for the sterile matrix. That means here the germinal matrix has to go in. So I will deepithelialize this part, because when you put in a nail bed, if you just make a hole, it will be fat. I think it cannot have it. I think they don't survive. I think you need to deepithelialize it. So that means it survives. But then after this, what do you do with you need to have a sulcus. You need to have, so how do we do that? So after deepithelializing, I make a small incision over here and make a small pocket we make. So that's what has been done. So you made deepithelialized it, and then you make a small pocket. Up to that, you make a pocket. And this exactly is done. This is the deepithelialized. See, that's what we took it, and this part of it is deepithelialized. So this deepithelialized surface is there. This is the undersurface of the nail. So you put it and then push it inside. You push it inside, and you take stitches like this. So that means now this part of it is inside. So you get something like a nail in the end of the finger, and that's how it comes. So at this stage, when you had a finger up to that, you had another 2 inches. So that's we just leave it on. The nail starts coming over here. It looks as if they've got a small sulcus over here. I think that's it. So now you've got a syndactyly. You need to separate the syndactyly. Almost always now you require a big full thickness grafts you will need. At the time when you are separating the syndactyly, debulk it. You debulk it, drastically debulk it, and that's that. To reach that level you reach. And then last stage, you require, because we have cut it, there is no DAP joint, and this finger was not moving before anyway. This finger was not moving. So now we have make it, arthroides the finger so that it becomes painless. And again, you debulk it. And 2 years later, because it's a progressive macrodactyly, they keep growing. And that's it. That's the end of the, up to the stage you reached, and then the parents were quite happy. So you do have a sulcus here, you do have something like a nail here, and that's what we reached from a stage where you reached it. I think to that I find even the parents are unhappy, they want to get it done. So then the X-rays we start here, and because we do a laterally, we cut this thing, so that means you laterally you find that the X-ray and the long-term result they appear like this. So that's easy. So if you have a thumb. So thumb, we can't amputate. So what we do, again, I draw. I think how I just want to see how it looks, where it will look. So again, we take the nail bed, and then we put it on. When you do this first stage, we put this, once you get, you need to put this nail bed at a start, where you think ultimately you'll require that. And then this is the first stage you do this. And then, say now it looks good. And after that, you need to make the thumb meet the fingers. The thumb becomes functional when you meet the fingers. That's very important. It has to meet. For that, these children do not have proper muscles. They don't have movement. And then for that, you need osteotomy. I think we still have not done that in this boy. So we reached out to the stage. We need to debulk it here, and I'll do an osteotomy so that I'll find out where these other fingers go. And at that stage, I'll position the thumb so that it meets the fingers. Now this comes to another, then there's the last one. This comes to a bigger stage. So if you have such big fingers, so this child is from abroad, and then so many times we send the child back, and then said, we need to have the 5 fingers. So that's the way the X-ray looks. And after long discussion, we took over the shot. The same thing. You take it up short, and here in the beginning, it's as a start. The nail is not good. The nail is not good in the state, but then we require only a small part of it. That's the nail bed that I harvested from here. So I'm trying to put it in this spot. So when the child, when it's so big child, it is so big in the beginning. In the first time itself, you reduce the length part of it, you reduce. And then you start putting the nail bed graft at the end, and it looks like this. In the first stage, it looks like this. So the germinal part, matrix part of it will be here. I think it goes into a small fold that you would see. And then we start separating the syndactyly. I think you start separating the syndactyly. Syndactyly looks like this. And then on the volar side, you start. There are progressive macrodactyly. They think they'll grow. So you do this. And then after this, you need to reduce the size of the bone, because by the way you reduce the size, you almost go to the base of the middle pharynx. I think you'll be going to the base of the middle pharynx. And after that, you make a longitude on both sides, you cut the bone. You think you're going to cut the bone. I agree with Scott. Now you need to separate you need to release the carpal tunnel. Sometimes many of these children cry incessantly in the night. That's the carpal tunnel syndrome they have. You need to reduce it. And that's the child, we got why, say when you child, I think this is the reached child you reached. And that's the X-ray that we find. You will find that we've done so much of hand surgery we do. I think some parents and some children are very happy. I think this is one of the parents who have been very happy. If you see this child, if you find out whether they use those two fingers, they don't use those two fingers. And they were not using those fingers before also. But for pinching activities, I'm putting this video because one of the aim was by our surgery, we should not in any way downgrade the movement of the rest of the fingers. See this, by our surgery, we are not downgraded the movement of the fingers, but then we are satisfied the parents. We are giving them a broad palm, and when they hold a bigger thing, see that's the fingers. When they hold a bigger thing, that means now they are able to hold it up. So this child goes for even Bharatanatyam dancing. When they hold bigger things, he says that's the greatest advantage we have is that the span of the hand is wider. So to summarize now, if the expectations of the patient, that means the parents, and our capability match, then there is no problem. But then if there is a gap, that means there's the problem. So the challenge is to make it happen. And this challenge is there in every congenital hand surgery. And in such big macrodactylies, it's more of a challenge. Thank you so much.
Thank you, Raja, and thank you, Scott. Great talks on a very challenging topic. We'll run through some questions. One of the questions is to Professor Cozen, what are your views on digital nerve resection and autologous nerve grafting for nerve territory orientated macrodactyly? You're muted, Scott. Yeah,
I got this new headphone. I'm not used to it yet. So, in children, if a digital nerve is enlarged, we typically resect it. We don't necessarily graft it because the other side of the finger will lead to improved sensibility. So it's overwritten that babies need to have that nerve grafted. You just leave it alone. The other nerve, the other proper digital nerve, will take over for the isolated resection.
That's great. Roger, can I ask you, have you got any experience of free tissue transfer into a resection bed, having amputated some digits and a thumb and perhaps an index finger? Have either of you had any experience in terms of microvascular transfer of digits into that bed?
I have one patient who has got a huge thumb, and he also had a huge index finger. So we have amputated the index finger, and the thumb also I'm going to amputate. But for the COVID, he should have come. The plan is to amputate the thumb and do a toe transfer. My idea was to amputate the thumb, and because the three fingers are good, and if you could, I got sufficient amount of tissues I have stored. Then I'll amputate the thumb and then put in a second toe transfer with the metatarsal, so that we'll wrap it up, the metatarsal part of it, and the rest of the three fingers will move and meet the thumb. I think that's a good idea. I think Simon K has done this procedure. Simon K has done this procedure.
Yes, I think he's published a case report on that, I think.
Yes, his case report, and I'm looking forward to do this, because many a time when these children I talked to, now nobody has agreed for it, and now I got a patient now who has agreed for it. Now I've got the parents who agreed for it. So I think that will be the next thought.
Keen to see the results of that. Scott, do you have anything to add to that?
No, I feel exactly similar. It's similar principles to toe to hand transfer. So if there's a good CMC joint, then it deserves a toe to hand. It's nice because, as Simon talks about, the proximal enabling structures, that's the term he uses, are normal. So there's going to be plenty of nerves and vessels to hook up to. It's not like doing a toe to hand for a congenital difference where the proximal enabling structures are not normal because it's a post-zygotic mutation. It's a perfect indication.
One final question, if we've still got time. Do you do anything preemptively for the high chance of hypertrophic or keloid scarring in these situations? Do you put steroid in when you're closing? Do you warn parents? How do you deal with that situation?
So Raj, I'll go first. So Mary Beth Azaki has talked about the combination of macrodactyly and syndactyly, and that's truly prone to lead to hypertrophic scarring. The only treatment that they have done that's been successful is methotrexate. So they've used methotrexate as an adjuvant around surgery to diminish the postoperative hypertrophic scarring. But we have not done it, but I know Mary Beth and Scott Oishi have done it.
Roger,
We
do you?
don't, we don't do that because I'm so worried. I'm worried to inject steroid because already I'm very worried about wound healing in these children. So I don't do that. But then once the wound heals, now we're going for a good amount of compression. You see that one child we showed, but the rest of the children didn't have much of hypertrophic scarring. So massaging and then silicone gel sheets, wrapping up. I think that's what we do now.
Great. Do we have time for more questions, Wee?
Absolutely. One more.
Yeah. Could you talk to us, Raj, if you could start about timing? There was a question about how you differentiate static versus progressive early on when you see a child, and timings of intervention, particularly when you're in the static type, when you're trying to keep the digit.
Yeah, since the progressive, I think if you look at it, you will know because it goes by the history. And you ask the parents how much it was when the child was born. And if you just ask them a simple question, is it growing much more than the rest of the finger? I think it's growing too much. Yeah, they said it's growing too much. So there's all such cases are progressive macrodactyly. All the pictures now, it's got so nicely showed, but most of them are progressive macrodactylies. And static in macrodactylies, the question is whether you control the growth. I'm so worried to do the BFIRST disease of these children. I not had much of experience because I really like to maintain whatever the movement that they have. And only in cases where we have done the joint type of work very early is in hyperostotic types, where they are totally not mobile, they are not in a good position. So there we do that, and in the joint work you do and fix it up in a position where it may be more functional, so the thumb meets the fingers. Scott, what's your idea, Scott?
I don't think it's difficult to differentiate. You usually know pretty early on.
Yeah.
Static, they're just different entities, and it's not like a challenge to make the diagnosis. It's just the progressives are just crazy, like I showed in the pictures.
Yeah. Time will usually tell. Great. Thank you both very much for some great talks and great images.
Thank you very much. We're going to take a short 5-minute break just for everybody to go and get a drink or whatever, 5-minute break. There are still lots of questions, fascinating questions. If I can ask the Scott and Raja, especially if you can answer some of the questions on Macrodactyly. Type it as you go along whenever. So we're going to come back in 5 minutes, okay? So sort of just before 3 o'clock. Okay. Okay, we're gonna make a start. Just wait for people to come back. Okay, so we're gonna move on into our last session. I want to introduce my moderators, our moderators for this session. The first chair is Ruth Lester. Delighted to have you with us, Ruth. Ruth is an honorary consultant plastic surgeon in Birmingham. Ruth created the charitable fund CHARMS, which is Children Hand and Arm Surgery, which supports the work of the Children's Department in Birmingham. She currently chairs the National Congenital Hand Consensus Group as well. Ruth had previous experience of living and working in East Africa, especially Uganda, Zanzibar, and Nepal. And she didn't want me to say this, but I want to say it. She was recently awarded an OBE in recognition of her many years of dedicated work in hand and upper limb surgery. The second chair is Mo Abdurrahman, who is a good friend. He is the Assistant Professor of Plastic Surgery in Khartoum, Sudan. He graduated and did his MD training in Sudan. He spent 2 years of fellowship in Chang'an Hospital, as well as different fellowships in the UK. And he works very closely with BFIRST and BSSH in helping us. So let me pass the time over to Ruth and Mo. Thank you.
Okay, thank you very much, Wee, for your kind words. The world's very small, and I feel very excited about being part of this group. A bit daunted by the technology, you know, with my white hairs. It's taken a while to learn about it. Each one of us has a huge amount of skills around this room or Zoom, which can improve the lives of children with hand differences. You know, so many won't have the access to the geneticists and the help. And you, as Jill says, we have to do it. You have to do it yourselves and be cautious. I think we'll go on to Dean. It'd be great to have some questions for us through the Q&A system, if you can. I've also known Dean for many years, and he passed through Birmingham on his route to become a very well-respected surgeon in Wales. I'm particularly delighted that he's going to become president of the British Society for Surgery of the Hand, which is a great honour and a reflection on his commitment to hand surgery at all levels. There's no such thing as minor surgery, and every parental and child's fear is genuine. And I know I look forward to the talk on, basically, in very English colloquial terms, wonky fingers, which Dean is going to provide for us now on camptodactyly, clinodactyly, and trigger thumbs. Thank you, Dean.
Can you see the screen, Ruth?
Yes. Oh, but you're not in the full slideshow. There we go.
Okay, great. So yeah, thanks for the introduction. And so Wee has asked me to talk about my approach to three things: camptodactyly, clinodactyly, and trigger thumb in 10 minutes. So I'll give it a go. First of all, if you like your football, you may recognise this chap. He's called Darren Bent. He was a Premier League footballer. He plays in the lower leagues now, but I put him up because the term camptodactyly comes from the Greek campsi, which apparently means bent or bending, and it's synonymous with another term which is called campylodactyly, which comes from the Greek from arched. There's a beautiful sea arch just a few miles along the coast from where I live. What we're talking about is a non-traumatic flexion deformity of the PIPJ. The MCPJ and the DIPJ are not affected, and it usually affects the little finger. And there are three main types. Type 1 is infantile and usually affects the little finger only, and has an equal sex prevalence. In type 2, this is the pre-adolescent type. Usually affects girls and may progress to quite a severe deformity. And then type 3 is the more syndromic type. See if I can get rid of that, which tends to affect multiple digits in both hands. So I just need to, seem to have crashed. Stop sharing for a sec. I'll just try again. Okay, so camptodactyly for me of less than 40 degrees is purely cosmetic. It doesn't interfere with function. I usually, if they want anything, give them a splint and tell them to go back in a year and hope they don't come back. And really, that's the basis of my treatment for camptodactyly. I tend to avoid surgery if at all possible. If they've got a contracture of more than 40 degrees, again, I tend to try and promote non-surgical management, and I tend to think about intervening when it gets to about 60, 70 degrees. If you can't have access to splints, then the Koreans have shown that if you do passive stretching of at least 5 minutes, at least 20 times a day, then that can improve the contracture. And I think that may work with very attentive and regimented Korean families, but I think some of my patients may suffer. Mommy. Shut up. And I don't think they do so well. If I have got to operate on these, then I tend to reserve the surgery for severe cases with failed conservative management. Because, of course, surgery carries risks, not least of which is loss of flexion. What I tend to look for in the finger is whether the contracture is correctable. So you look at it with the MCPJ straight, as in this case, and then flex it. And you can see you get far more extension when you flex the digit, indicating, well, two things really. Either they can have a shortage of skin, or there's a tight or abnormal structure on the front of the digit. And when you explore them, probably the commonest anomalies, if you find anything, are an abnormal FDS or an abnormal lumbrical insertion. And that lumbrical can be inserted into the FDS itself. It can be inserted into the flexor sheath. It can be inserted into the joint, or it can be inserted into another finger. And really, when you think of an intrinsic deficient finger, it's pretty logical to assume that it will assume an intrinsic minus position. And if it's there for a period of time, then it's likely that there'll be articular changes in the PIPJ, which are typical really of what we see in camptodactyly, where you get hyperplasia of the proximal phalangeal head, notching of the neck of the proximal phalanx, and widening of the base of the middle phalanx. If I am forced to operate them, I tend to operate them in a pretty methodical way. I don't approach the joint. I simply explore over the proximal phalanx, usually with a Z-plasty, or sometimes in the little finger you can use an axial pattern flap, or Lindley Wall, for example, has described a stiletto type flap with colleagues. But when you're in the finger, then inevitably you find tight fascial bands underneath the skin, which you divide, obviously preserving the neurovascular structures. And then you incise the tendon sheathage distal to the A2 pulley to allow extension of the digit. And then you tend to explore the finger in a sequential manner. So you've done that, and then you explore for an anomalous FDS or lumbrical, and a tight or abnormal FDS is tenotomized, usually distal to the A2 pulley. I then K-wire the joint because I've not messed around with the joint. I've got no problems with maintaining my correction with a K-wire with at least 4 weeks. And I find that this doesn't cause stiffness at the PIP joint at all after a camptodactyly operation. So in summary then for camptodactyly, the majority of these can be reassured and treated conservatively. I tend to avoid surgery if I can, and if I do perform surgery, follow a sort of methodical stepwise approach, and only for patients with severe functional or problems that are resistant to therapy. Moving on to clinodactyly, which is bent in a different direction. This is congenital digital deviation in a radioulnar plane. And it's usually caused by a C-shaped epiphysis or delta phalanx. And it can affect any digit, but most commonly it affects the little finger. Indications for treatment, again, in my book, are functional, not aesthetic. Most of the patients that come to see me with clandactyly don't like the look of the little finger, but the function is very good. And I suppose another indication is to prevent progression of the clandactyly. And the options are to do nothing, to do a fasciolysis, to do a closing wedge osteotomy, which is not always, well, it's never really an option because you're usually dealing with a very short digit anyway, or you can do an opening wedge osteotomy. Fasciolysis was popularized by Vickers in the 1980s. To do it, obviously you need a digit big enough to do it. You need to mark out where your PIPJ and your DIPJ are. You can do this with image intensifier, which I tend to do and mark it out, or you can quite easily do it with needles. You then make a mid-axial incision, about 1 centimeter or so, and then you ablate the bracketed epiphysis. I tend to do it with a very fine rosehead burr, but you can do it equally well with a knife or a beaver blade. And then once you've done that, you use a little stab incision, you harvest a blob of fat, and then you can put that into the defect that you've created after excision of the bracketed epiphysis in order to prevent it from reforming. And then you send the patient away. The patients don't get stiff, they move very early, and then you review them every couple of years. It's important you obviously tell the patients that the digit is not going to be straighter after the initial operation, and it's going to take a few years for them to see any effects, but it does work. This is a child on the left who's about 6, I think, and about 12 there on the right. So it gradually straightens out over time, and you can see it radiologically. This is another patient, age 7, just before surgery, and then age 12. And then age 15. So it does gradually work. The finger's never very completely straight afterwards, but they're certainly much better. But the normal little finger's not entirely straight anyway. Some very eminent authors looked at a combined group of their patients, 27 fingers, and found that with a main pre-op angle of 38 degrees, this improved after 6 years to 8 degrees after fasciolysis. You can do osteotomies, of course. You can do a corticocancellous graft for your osteotomy or a cancellous graft, or you can just leave the gap. And indeed, Chuck Goldfarb and Lindy Ward described their experience with osteotomy. What they do is they pass a retrograde K-wire just radial to the axis of the joint, another K-wire to stabilize the PIP joint. They do their osteotomy and then advance the K-wire and put another K-wire in to support it. And these are pictures from their paper. So relatively mild clandactyly there, and then the extensors retracted, they do a subperiosteal dissection, osteotomize, and then pop the KYs in. I've got to say, I've done this operation a few times. I find it a very difficult operation. I find it very fiddly to do. And I also find that the DIP joint gets a little bit stiff afterwards as well. So it's not a common operation in my practice. So again, in summary, clandactyly is usually a cosmetic and not a functional problem. Fasciolysis, I find, is an effective treatment, and the indications in my practice for osteotomy are few. So last thing now affecting the digits is trigger thumb. This is a common condition. There was some debate about whether it was developmental or not, or whether babies were born with it. And it's pretty well established now since Slatey's paper, I think, and a few studies since then, that it's not present at birth and that it comes at some stage after birth. And they may present with triggering, but usually they present with a flexion deformity. When you feel over the metacarpophalangeal joint, you usually feel a nodule in the FPL, of course, which is not as nodule. And you can treat it in a variety of ways. A lot of people watch and wait. Bake's paper showed that if you wait, then 63% of them resolve. I've got to say that's not the case in my own practice. And I find this age group a very difficult group to try and splint. And I tend to go for early surgery. And really, if in my practice it's not resolved by about 2 to 3 years, then I go for an A1 release. To do that, I make an incision across the metacarpophalangeal joint. You can see the child's got 2 metacarpophalangeal joints. You make an incision between, 2 joint creases. You make an incision between the creases, about 1 centimeter or so. Got to be careful because obviously the digital nerves are going to be pushed up by the nodule towards the skin. So you've got to be really careful going through the skin, and then put your scissors in and open them axially to dissect out the digital nerves, which are then retracted. And to incise the pulley, I tend to do this on the radial side to avoid damage to the oblique pulley structures. And then once I've done that, I deliver the tendon, have a little look at the nodule, make sure there's excursion of the tendon, and I usually give the volar plate of the IPJ a little bit of a stretch as well. After that, I tend to use some absorbable sutures and a very light dressing with the IPJ free. And really, I normally discharge the patients at that point. They usually get a nurse check or a therapist check at 7 to 10 days, but they really don't have any problems after that. So in conclusion then, I would say keep it simple and pick a winner. For Camptodactyly, I would avoid surgery if at all possible. For Clinodactyly, I think a Vickers procedure works very well if you catch the child early enough. And in a trigger thumb, I tend to release the A1 if it's not resolved by about 2 to 3 years old. So thanks very much indeed for the invite, and thanks for your attention.
Thank you very much, Dean. If you do want to ask a question, do go through to the Q&A knob on the bottom of your screen. If I could just, there is one question through for Jill at the moment, which I think is very relevant, and I know you sort of touched on it on your talk, but it's what advice would you give for people in LMICs with limited resources for accurate diagnosis? It would be worth, if you could reiterate the important features of recognizing syndromes for us.
Go back to basics, take a good history, strip the child off and do a good examination. Look for subtle signs of difference and be wary. The more limbs that are affected, the more likely there's going to be a genetic diagnosis. So consanguinity, family history, history of sudden death for Timothy's syndrome within the family, and then a full examination. And the more things you find abnormal, be wary before you jump in and do something. Most of these things can wait a bit if need be. And take other people's advice. And of course, WE has produced this fantastic app that should help.
Thank you. Is anybody else on the panel, Scott, Roger, who are around, have got any views on this question, which is very legitimate? Please chip in. The other thing, Jill, is in terms of operating, when age-wise, can we relax a little bit more that we know what's going on and it's safer?
Well, again, that depends on what resources you've got, doesn't it? Because we know that smaller children have a higher risk of anesthetic issues, and not just syndromic ones, but just normal laryngospasm and all those sort of problems from an anesthetic. So I think it depends what the condition is. If it's going to get worse, or it's going to be more complex to operate on as you get older, then you probably should be doing something earlier unless you've got a good reason not to. If it's not, then you've got some time to do things. And a lot of what we deal with in congenital hand can wait for a while. And often in other countries will present late as well. It doesn't always present at a very early stage.
Any comments from Mo or Raja in particular?
Yeah. So when I started my practice, I never could find out what syndrome they were. They all looked very different. But right now, I think it's pretty easy now because of the internet. And as Jill said, the most important thing is a good clinical examination. A good clinical examination, writing notes and jotting down things, and then you go back and the internet. I think now making diagnosis become much easier.
Thank you, Roger. No.
Yeah, I think I'll agree with Professor Babati. I'll go with the internet. I'll use the new app of WLAM.
Thank you. Moving on to, you can always come back. We can look on the questions later. Going on to Dean, I suppose I would personally argue with you about the trigger thumbs, which I think there are studies going around the world now which suggest that quite a lot of them do get better if you leave them long enough. And what would be the deficit if you left them?
Well, so as I said, there's no rush to do it. I mean, personally, I prefer to do it earlier rather than later, rather than sort of leave them with their child with a bent thumb. Let's draw attention to the hand, perhaps. When I start as a consultant, good few years ago now, actually, Ruth, but when I started, longer than I care to think, but when I started, I did try and leave a few of them, and I found that none of them resolved. And I think that an A1 pulley release is such a simple operation. I know all operations carry risks and stuff, but it's generally such a straightforward operation. It's easy just to get on and do it, and let the child get on, and as opposed to follow it up with splints and therapy for years and years on end. That's just my view.
Well, I can argue with you another time, Dean, but I think I felt the same as you when I started, but I think the evidence is getting clearer that it may not be necessary to do all of them, but that's another story. How important, the other question, I'm just having a look on my system. Have you tried reconstruction of the lumbricals in Camptodactyly?
I've found abnormal lumbricals, and I've tried to reattach them to the extensor. I don't know if that's what the question's about. I don't know if it's made any difference or not. I have to say, my results with Camptodactyly, again, when I started, I was very aggressive. I tried all sorts of tendon transfers, FDS transfers dorsally, and my results were universally very, very poor. So I just keep things very, very simple now. I release any tight structures, release the soft tissue that's tight, and I don't touch the joint or anything else.
Fine, I understand that. And there's another question which I will modify a little bit. There's how long can we wait for non-surgical methods for clinodactyly and camptodactyly? And I suppose it's a loaded question, is how important is therapy and the cooperation of the patient in managing the outcome for camptodactyly? It's a loaded question, Dean.
Yeah. Well, clearly it's really important, and you know, there's no point in operating them if they're not going to comply with the therapy, because the therapy is more important than the surgery. But you know, generally, if they want something doing, I'll leave them for a year or so, and with the therapist, and see what the therapist thinks. And if they're very, very compliant, then sometimes I get my arm twisted and I'll do an operation. But generally, I leave the sort of therapist make that decision. But if they're poorly compliant, then there's no point in doing it.
So you're saying if you haven't got therapeutic support, if you like, therapy support, you would not intervene, yeah.
Yeah, basically, because if you do an operation and then you just send the patient away, then the contracture is just going to come back.
Yeah. Okay. Any other questions from? Oh, I'm just looking again on my screen. No. There is one question about setting up MDTs to deal with syndromes. And Jill, it's aimed at you. If you could give us a word about the MDTs that are going on.
Yeah, I've just answered it actually. I think that for countries that have the opportunity, we do it, and we do it a lot, particularly for patients with craniosynostosis, where the most visible abnormality might be the hand abnormality, but we've got to check they can breathe and that their brain is not too squashed before we start operating on their hands. But at the end of the day, not all countries will have that opportunity. So in an ideal world, yes, but the truth of it is many of the people attending this will not necessarily have an MDT that they can work with, I suspect.
Now we've got Zoom, maybe there are more opportunities, Jill, for all of us to get together. Thank you very much. I really appreciate your both of you, your talks. And I'd like to hand over to Mo for the other two next two presentations, which I'm very excited about. Thank you.
Thank you very much, Ruth and Wee, and for the introduction. And it's given me an honor to be in this forum. It's a pleasure for me to introduce the next speaker, who is Dr. Abraham Gegzi Bahar. Abraham is a consultant plastic and reconstructive surgeon at the College of Medicine in Addis Ababa, which means the new flower. He's also the head of plastic and reconstructive surgery at Alat Hospital. Abraham is a long life friend, and he's one of the firstly trained plastic surgeons in Ethiopia. And now he's leading the way for the future of plastic surgeon. Also, Abraham was a BFIRST fellow in 2018, and he has been instrumental in setting the collaboration between Alat Hospital, BSSH, and BFIRST. Floor is yours, Abraham.
Good afternoon, everybody. I'm Dr. Abraham from Ethiopia. I'm a plastic surgeon. My short talk is going to be on congenital hand problems in Ethiopia. Ethiopia is the second most populous country in Africa. The population is around 205 to 210 million. And out of this, about 30 millions of the population is comprising of children, and that's about nearly 6% of the population. And despite having this big number of population, that we have almost non-existing birth defect registries. So it's really difficult to know the status of congenital hand and associated deformities registries. And the other scenario is that there are few centers which are attempting to handling of congenital hand problems. We have challenges, and that having got that, we have challenges. These challenges might be challenges that's related to patients. It's one that's cultural taboo. So parents with kids having congenital hand problems, they don't usually want to show the kids to the public, and that leads to that late presentations. And the other thing is that if they happen to come to the hospitals to have to look for a service, usually their expectation is usually 100%, and that just because primarily their intention is just not only functions, that to just avoid these stigmas. So that's also another problems. Now there is challenges regarding to the systems. There are limited level of evaluations related to because of the limited skill manpowers. We don't have specialists in genetics. We have few OT or hand therapists, and you can rarely get pediatric psychologists or pediatric hand surgeons. So all these problems lead to backlog, and that backlog also causes long operating hours and confusion of resources in limited hospitals or service giving units. The other thing is limitation with level of care, because these are kids might be syndromic with other syndromes, so they need special attention with regard to anesthesia. So difficult to get pediatric anesthesiologists, and the surgery is sophisticated. So the surgeons used to be on the trend, particularly for such type of handling such type of problems, and in addition to limitation with equipments like loops, microscope, and special hand units, hand surgery instruments. Opportunities, there are big opportunities on this side. One is having a good volume of patients is a good opportunity. That leads opportunity for research, and because we have a good number of patients with a minimum help, we can improve competence, and we can even develop a new knowledge and skills. That's one important thing opportunities regarding to the health providers. Just to show some of the patients that we are managing on this line, is the first one is the patient with Apert syndrome, where the patient had a previous release on third web space, and the other remaining were done in the second operations. The other patient is bilateral constrict band syndromes with amputation, especially on the right side, and even more deformed fingers on the left side, so that we did for this patient the classical release of syndactylis with the classical methods. Another patient with Aperts, and that is a post-operative case. Here is a patient with a bilateral syndactyly. This is a patient with another patient with Aperts with acrosyndactyly. A patient has real difficulty, and the whole hand is moving as a unit. So we interested to primarily focus on the first web space, so that we release the first web space, we put the skin graft, and we are looking at how the patient is going to function on the remaining, so that is one patient. Another patient, this is a patient who was operated somewhere else before, and the patient came with still with Synicas on the Synica on the first web space. So it's really difficult to release and maintain on that abducted position, so that we put the distractor so that maintains the first web space until the skin graft takes is acceptable. Another patient, these are two patients. The first upper one is the radial club hand with the right side. The lower one is the radial club hand on the left hand. The only difference is that the lower one is more severe. The contracture is severe. So we managed that centralizations of the ulna and releasing of the contractures. And in some of the cases, that we even need to put skin graft because the contracture is so severe, and even after doing bilobe soft tissue coverage, still in some of the patients needs skin grafts. The other opportunities for the systems, the initiation is ready for international collaborations. That international collaboration has a sort of win-win environment for us. It gives them that a good skill transfer for a person coming that to collaborate, or a unit that for collaborations. That's also another issue regarding to the research and having that good volume of patients. And the other opportunities for the system is that if you are going to establish a good congenital hand services, we can expand the service for the population, one. The other is that having this new venture with the success in establishing a good congenital hand service units, that also can be extrapolated for other congenital diseases like craniofacial disease and so on. Thank you very much for your attention. Thank you very much.
Thank you very much, Abraham. Thank you for sharing your experience with us. It's quite amazing and like a humbling experience. I think it's time for poll now, poll number 4. So the question of the poll saying, do you know how many surgeons in your city/country are managing congenital hands condition? So I think most of the audience is like 79 which represent 46%. They have more than 10%. That might represent who's the audience is now. The next group is 1 to 3, and we have then more than 3 and less than 1. Yet it tells like how scarce this sort of like subspecialty sort of, which will need a lot of investment in it. Thank you. Our next and last speaker is Shilu Shritha. It's given me a pleasure to present her. Dr. Shritha is a consultant hand and reconstructive surgeon from Nepal. She graduated from the medical school in Nepal and went to achieve master in surgery in orthopedics and a clinical fellowship in hand and reconstructive surgery department in National University of Singapore. Her major interest is in congenital hand surgery. Sheila, thank you very much.
I'm Shilu Shritha. I'm an orthopedic hand surgeon from Nepal. Nepal is a beautiful country with 8 of the highest peaks in the world and gives you a lifetime experience during the trekking. But it's very difficult for the people who are actually living in there. The urban population, like Kathmandu, constitute only 17% of the total population, and 25% of the population lies below the poverty line. The challenging geographical terrain makes it very difficult to access the healthcare facility, and the mode of transportation is quite primitive and heart-wrenching. So my journey towards hand surgery begins with this boy of arthrogryposis, whom I saw during my residency. He complained to me that we just fix his feet, which he could have easily covered under the shoes, and never fixed his hand, which is always exposed. That's why he doesn't want to go to school. I went to my senior colleagues and asked them why couldn't we fix his upper extremity, and they said it needs a special expertise, he needs a hand surgeon. So I decided I want to become a hand surgeon to fix his hand. So my training in Singapore had a profound transformation in me, and I came back with lots of enthusiasm. In my early days, I went to a surgical camp where I saw this girl with complex syndactyly. I had observed only one case of simple syndactyly during my training, so there was no way I could fix this hand in a surgical camp. So I asked the mother to come to the central hospital, but the mother started crying and she said this girl is abandoned by the family. Because of her disability, they have to pay tons of dowry during her marriage. So she somehow managed up to the camp, and there is no way she could come to the central hospital. And if we could not help them, they don't have any other option than to just keep up with their life. I had lots of pressure on this, and I wrote to my mentor in Singapore, how should I manage this? My mentor wrote me back saying, it's a complicated case to manage in a camp and you are just a beginner surgeon. But if you really have to do this, just follow the basic principle and do your best. And I did the same. And to my surprise, this girl presented after a few months to the hospital with other 4 girls with similar kind of problem. And they were so happy that they could go back to their family after the surgery. And that day I realized I just did not reconstructed her hand, but I reconstructed her life. And that gave me a lot of drive to continue with my work. And so these are the common conditions that we see in the clinic, the commonest one being syndactyly, arthrogryposis, and so on. And these are the conditions that we treated so far in last 6 years. The percentage of girl child is not as less as in other conditions. I think the reason must be the same as I stated before. More than 50% of the children presented after 4 years of age. And few of the conditions that we have treated here, the case of simple syndactyly, I used to reconstruct the web space by the dorsal rectangular flap. And nowadays I split the dorsal flap and interdicted it with the volar triangular flap, and I think this has given me a better result. Case of Apert syndrome after the release and after 3 months. This girl presented after 14 years of age, and when I asked her to write, she seems to be quite adapted with her hand. So I scared that if I would do some release, I would compromise her function, so I did not intervene her. This girl with crossover type of syndactyly, I just followed the basic principle and did the release. So this boy had a complex syndactyly and had a functional problem as he was not able to bend his central ray. So this is his X-ray. So I reconstructed his tendons and I removed the ulnar ray and did the corrective osteotomy of metacarpal and was able to gain some flexion, but I could not see his follow-up as he never turned up. The other common condition, constriction band syndrome, very simple surgery with promising results. Polydactyly, this boy had thumb duplication and I had to reconstruct the tendon and the joints, but I was quite criticized by some of my senior colleagues and my anesthesiologists for taking so long time just for an excision. So arthrogryposis, I had a very rewarding result with dorsal carpal wedge osteotomy for the flexion contracture of the wrist. So Macrodactyly is not as uncommon here, and most of the parents want them to get it released, even though they have to compromise with some flexion. And I must say I have been quite fortunate to have some motivated physiotherapists, even though we don't have occupational therapists here. The other problem we have here is we don't have geneticists, so we cannot specify the syndrome. This syndromic boy with the clasped thumb, we released with the index finger rotation flap, and this is after 6 months of the release. So cleft, bilateral cleft hand, and we just released the syndactyly, and this is after the release. So far, whatever we are seeing, I think it's just the tip of the iceberg, as this is the population who cannot reach us. We have to reach them through camps, but we don't have much fund for this kind of conditions in compared to cleft and the burns. So at the moment, we are left with this conflicting reality. So one side we have poverty, geographical challenge, illiteracy, social taboos, and political instability. Versus other side, we have preventable disability with late and complex presentation, which makes the treatment even expensive and which needs long-term care and expensive technology. Thank you.
Thank you very much, Shilu, for sharing your experience as well with us. And thank you for great work as well. I'm sure a lot of audiences here, like myself, are inspired by your talent and the great effort you and Abraham are doing in spite of all challenges. I think it's time for questions. Do we have time for questions?
Yes, we have about sort of 5 minutes or so.
Okay. So one of that, it's not a question. I think actually it is one of the audiences has written an inspiring talk. Thank you very much. Keep great work continuous, great surgeon you are to fight with such a community. That's really good. So I have a question. Abraham and Shilu, how many therapists you have? Do you have a therapist to support your work at all?
Hello. Yes,
Abraham?
we have. Yes, we have a physiotherapy unit in our department, but there are some of them who are especially working on hand therapy, and we have also one occupational therapist working with us. That also give us a good chance for following the patients.
That's good.
Otherwise, the problem is that we don't have those physiotherapists specially trained for kids, and that is one challenge.
Thank you, Shilu.
Yes, we also have a physiotherapy department, and I make sure that the physiotherapist, which is mainly dedicated to hand, I have two therapists who are more dedicated to hand, and I make sure that they stay in the clinic with me and see the patient preoperatively and post-operatively, and they have been quite motivated, and they are so motivated that whenever I call them in the theater to show the cases, they would even come to the theater and sometimes assist me. So I've been very fortunate in that regards.
That's good. I have a question here from Obaid. Thank you, Shilu. Do you do the surgeries alone or call other hand surgeon for elsewhere, like abroad?
Sorry?
So the question was, do you do the surgery by yourself or you ask for help, especially for complicated cases?
Yes, definitely. Most of the cases, if it's too complex, I always send them back home and call them again next time. And in that time, I would also consult with my seniors, my mentors from abroad. And also that would give me a time and also know the commitment from the patient, because if they come back for the surgery next time, I'm sure that they would come back for the therapy.
That's good. I think during this COVID time, that made us like appreciate the technology more, honestly, like now in consulting and sending through, WhatsApps, etc. If there's no more questions, thank you very much. And back to you, Wee.
Thank you very much to the moderators and the speakers of this fantastic session. We're going to come to our last bit now, and we're going to try to involve as many people as we can. So we're going to focus on some complex case or cases or just not necessarily complex, but with great learning points. The idea of this case discussion is to try and bring everything we've learned together, learned today, together at this point, and try to apply some of the principles. And I've chosen some of these cases for this educational people have submitted. Just a reminder that you can send in cases for discussion. Please email them to MR Brighton. So far, we've only had very few, but there's part 2, so please feel free to do so, okay? So I'm going to just pick on the panels, if that's okay. Now, we're going to start off with a case from, this is from Pedro from Mozambique. I'm gonna present the cases, okay, because of time. This is a 3-year-old bilateral symmetrical syndactyly of all 4 fingers. There is also with fit syndactyly. There is a positive family history. Mother has non-operated syndactyly, and I'm gonna sort of do this in a way that I will have very focused questions for the panel, so that we can make this as educational as possible. So the first question is to Jill. Are there any syndromes or association you would consider for this?
Well, the fact is it bilateral? Yes, bilateral. It's going to make me think there's probably a syndrome. It's also a family history. It's certainly going to be genetic. But it's not APERTS because you've got PIP joints that are functioning, and you can see that on the top right slide, where you can see that. Now in APERTS, you're going to get just MCP joint motion, so you're not going to get that. Could be a Fraser's, but I'm not seeing anything else, and no other comment is made about any of the others.
Okay, right. Thanks very much. Bran, how would you approach this hand surgically?
I just unmute myself. You can see the length discrepancy is an issue. The X-rays, sometimes when you have multiple syndactylies, can be a little bit confusing because of the overlap. And I think a very useful point to take home is that at the start of the procedure, this is something that Jill taught me when I started, is that you can gather a lot of information about the case. When the child is under anesthetic, don't just rush straight into the procedure. Take your time to get the image intensifier in, to really take that opportunity at the beginning before you start to examine the hand very carefully. And that 10 minutes or 5 minutes at the start of the procedure before just launching into the operation is very valuable in the decision making. And that should be brought up with the parents as well, to explain to them, to give you some flexibility to make changes intraoperatively if you feel that's appropriate. But I would opt to get the border digits out if this if I felt that there was a good osteoarticular column within the little and index finger, I'd be looking at the joints. I would then probably do a parallel procedure 2 weeks later, maybe change the dressing on one hand and do the other side. It would be staged releases, minimizing anesthetic time, but I would carefully plan intraoperatively as well as preoperatively.
So you do one hand at a time, yeah?
I would do one hand at a time,
So
yeah.
for the digits, you mean the ring and little finger or index and middle finger?
I would get the index out as well as the little finger out, because I think they may be causing some tethering. You can see the PIP joints of the middle and ring are slightly more proud. But again, you know, it's easy to look at the picture. You'd get more of a feel by actually examining the hand, both preoperatively and at the start of the procedure.
Great, thanks. Scott, would you do this both hands at the same time or one at a time?
We would probably do both hands at the same time. And we would also do the second and fourth web spaces. We wouldn't use in the stingray flap that we spoke about earlier. We'd probably use a standard flap because we're gonna have to come back into do the third space.
Okay, great. Thanks. Paul, would you do this with graftless technique? And can you do it for all the digits with a graftless technique?
I think I'd agree with second and fourth to begin with. I would use the stingray flap in that instance for two reasons. One, you can reuse the scars for the third web. But secondly, the ring and middle finger are quite splayed on the X-ray. And so there's a little bit more skin in that web than in the others. I think with this particular hand, my screen isn't very clear with the X-ray, but the tips would suggest that they are fused, although that may be the overlap. It may be necessary to use a butt gram coat. Well, it will be necessary to use a butt gram coat at the tip, and possibly either have some small areas of granulation, or we may have to take the step of a small skin graft distally. But I think proximally, looking at what we can see, the arch of the digits in the sort of transverse plane gives you a little bit more skin than you think you have.
Great, thank you.
Alternate hands, yeah.
Okay, so this is what has been done, and just to I think the learning point here is that we could separate the ring and little finger and the index and middle finger at the same time. Any other comments? Jill,
Well,
any comments? Sorry.
Just one quick comment. I think sometimes if this takes longer than you anticipate, it's totally fine to stop and come back another day.
Okay, great.
So yeah, if this web space took longer from a tourniquet time, then we would just stop and come back. It's totally fine.
Okay.
Yes? As far as the bilateral surgery, I often have a conversation with the parents. Like I think Scott said, I tend not to operate bilaterally if they're older than 18 months, because I find that the child gets very frustrated with both his hands tied up. But if that's what the parents want, then I do it that way.
Okay, great. Okay, so this is how the complex case is going to go, all right? So that was the warm-up. Right, this is a case from Bangladesh, 9-month-old girl, no obvious syndromic features. On the right hand, I'm not going to name the digits, so I'll call them just fourth and fifth digits. So there's syndactyly of the ulnar fourth and fifth digits. And on the left hand, there is syndactyly of the ulnar 3 digits. There's also polydactyly of the left foot. So question to Jill again quickly. Any syndrome association to consider?
Has syndactyly, you get syndactyly and polydactyly, but I can't remember if the feet are involved as well with that. But they don't normally have other problems.
The feet, polydactyly on the left foot.
Yes. But certainly has you get this sort of polydactyly.
So, sorry, what's that?
Has syndactyly.
Has syndactyly, okay. Raja, how would you approach this hand surgically?
So the right hand, I think we see the 3 fingers are good. On the ulnar side, 3 fingers are good. I'm sure they should be functioning. I will assess the the index finger. Maybe it looks a little bit smaller. And I'll assess the function of the fingers on the radial side. Whichever is good, I would make them one finger. Choose that finger and then try to make them meet the other fingers. So that will be the thought for the right hand. And for the left, I'm not able to see the X-ray. I'm not able to see the, yes. So now here again, it looks like what we need is to create a web in the first web space. Though it look, they're all been the same plane. I think I'll try to remove some things so that we get some more tissue, make a bigger web, and make it rotate. Whichever the metacarpal which is more rotating, so I'll use that and place that, and then try to see that they meet the other fingers. That will be my choice.
Okay, Scott, any thoughts?
No, no, I agree with
what
Rod.
would you do with the thumb?
Yeah, so we would use the principles of spare part surgery. So as Dobbins taught us all, we would make the best thumb we can out of those 2 radial digits in some way, shape, or form, and widen the thumb index web space with some type of dorsal rotational flap.
Okay, so let's see what has been done. This is on the left hand, the one with more of the syndactyly. I think the first stage, from what I can make out from the slide sent to me, was that the third web space was separated first. And then in the second stage, the more border syndactyly was released, and the ulnar digit was removed for the thumb. Any hands? No? Okay, so I think fantastic result. On the left hand, that was removal of the ulnar digits, and on the right hand, I was told that it was removal of the radial digits because this was very hypoplastic. Very functioning hand. At the moment, the problem is that there is a flex deformity of the left thumb, but other than that, very functional hand. Any comments? No? No? Okay, let's go on. Okay, so 6-month-old boy, no obvious syndromic features. This is one for you, Scott. Unilateral syndactyly of all digits and duplication of the index distal phalanx. You can see here.
Yeah, this is a very difficult hand. I mean, it really requires some time thinking about how to reconstruct this hand. But clearly, the digits are of relatively equal length, so there's no hurry. So first and foremost, I would not operate at this age. I'd wait and let the child grow and watch them from a serial exam standpoint. If you look at the x-ray, obviously you see there is a thumb based upon the bony anatomy, but that thumb is tucked into the adjacent digit, so it needs to be moved out away from the attached index finger. And it would require a large reconstruction of the web space, but we wouldn't do surgery on this child until they're 18 to 24 months, and then we would have a staged approach to separate the fingers and yield a thumb.
Okay, what flap would you use for the first web space?
Yeah, so it's a great question. So sometimes we'll use a flap. Sometimes we'll almost treat this like a policization, where we'll design a policization incision to get us the best thumb index web space. I have to think about it.
Okay, Jill, what do you think, Jill?
I think it needs a decent amount of space, and there's a multitude of ways of doing this. You're not going to end up with really, really great hand function, I don't think, because you've got short fingers that've got limited amount of bend, I think, probably in them. So here, local flaps, you're going to cause some quite significant scarring, but you could do an extension of big dorsal rotation in the way they do from Boston. But, you could do a pedicle groin flap on this, you could do a free flap on this. And I think it depends on your abilities and your resources. And I'd be quite keen to get out that thumb early, actually. So I probably would do differently from Scott in that respect. I'd be trying to get the thumb out early and get them using it.
Okay, you have to answer the question. Are there any syndromes association to consider?
I mean, this could be a Symbrachydactyly, but it's unusual to have the extra duplication. So it could be a very unusual cleft hand is another option.
So you have to check the chest muscles, yeah? At a very minimum.
Because it could be a Poland's if it's a Symbrachydactyly. And with that, you also want to check
Raja, any?
well.
Yeah. So I think if you see this thumb, I think thumb is well formed. So I'm sure that you will get a good result in this case. And usually these children have got some amount of thenar muscles also there. So around, I agree with Scott, around 18 months, open it widely. I think you open it as wide as possible. Only thing you need to see if there are adductors, just don't cut them, because more than pulling up, it's important to get them back holding it. And when I make this, when I separate, I'll try to make a big flap, some local flap into the web, and the rest of the sides, put a graft.
Okay. Right. So this was what was done. I think a second stage or a redo of the first web space probably will give a good result, reasonable result. Okay, and right, 3-month-old boy. Obviously, we won't operate when the child is 3 months old. No obvious syndromic features. Unilateral syndactyly of all digits. We start off with you, Raja. What would you do?
I think here anyhow, I wait beyond a year, so beyond wait a year, and then try to find out if we could try to make anything 2 parts of it. I'm so tempted to release it and see. I think that's what we need to do, I think. And there's nothing more difficult, there's nothing more we can do. Try to separate it out as much as you can. And later on, rotate it by osteotomy.
Okay. Bren, what would you do, Bren?
The flat hands are pretty challenging. Again, I would wait. You would really want to get something for the fingers to oppose against, and that would involve a rotational osteotomy of the thumb side. But the lack of creases on the palmar side is a little worrying, but the priority would be to get some form of web space and opposition if possible. But I would wait a little while, because there isn't a big length discrepancy at that stage. Perhaps the little finger side there is, but there is an argument to wait a little bit. But that's what I would be aiming for. But it is a very challenging case.
Okay. Scott, I'm going to ask you a very specific question. Would you separate all the digits?
No. So if you look at that long finger, we would probably fillet that digit and use the skin, because it's not connected to anything. So I don't think that long finger is going to be functional, but I would take advantage of using the skin of the long finger as skin to help me with my reconstruction. One quick comment about the rotation. It looks easy to rotate that thumb out of the palm. It's not easy. Even if you take a wafer of bone, for some reason it wants to spin back in. It's very difficult. You need 2 K-wires to try and keep it out, but be prepared for some recurrence.
Great. Okay, so this was what was done. Again, a similar flap. I think this is just to illustrate the principle that this is the flap that Scott described, I think, and you just stick to principles, manage to get the thumb out. This is the status that now I'm not really sure whether I can separate this, but this is what I got, and parents are delighted. Okay, we're just gonna move on. So this is a 6-month-old girl. No obvious syndromic facial features. On the left hand, you have a complete syndactyly of the 3rd web space and a duplication, I think, of the middle finger, or one of those. And on the right hand, you have a complete syndactyly of the 3rd web space. So, questions? Any syndrome or association to consider? Jill?
It's bilateral. This central sympolydactyly is often related to HOXD13 mutations, and I would also want to look at the feet and look at the 5th digit and see if it's duplicated at all with a tiny little extra nail, because that's quite common, but it doesn't always occur. But this would have a high chance of a family history, I think, and therefore also other children being affected in the future.
Okay. Paul, any surgical considerations?
Well, I think we're looking at polysyndactyly in one hand. Surgical considerations would be timing of surgery. Again, I'd probably wait till 12 to 24 months, sometime in that interval. I'd probably address the polysyndactyly side first because of potential growth differences after a long and frank discussion with the parents.
Okay, anybody wants to see the x-ray? Shall I bring up the x-ray?
Yeah, sure.
Go on, Dad.
Oh, wow.
Oh, okay.
So there is no polysyndactyly site, Paul. They're both polysyndactylys.
Yeah, it's absolutely classic HOXD13 type mutation, isn't it? And they're going to have abnormal vasculature, and that's where your issue is going to be. You might even have one vessel for 3 digits.
So, Paul, what would you tell the parents preoperatively?
I think in that instance, it would be reasonable to investigate the arterial anatomy with an arteriogram.
Okay.
Fine on the right to take that middle digit out, or the duplicate middle or duplicate ring finger, whichever that is, and achieve a reasonable syndactyly correction. The left side, of course, with the complexity around the MCP joints and the duplication, it may well be tempting to leave that and not separate it, but looking at the angulation and the way that the growth plates are going to drive that central mass out to the ulnar side, I think you'd have to consider an osteotomy of the metacarpal to take the aberrant MCP joint out and separate out the middle from the 3 digits.
So I think what we will tell the parents beforehand is that it's not easy surgery and you may not get it separated all at the same time. I think this is just to highlight the case that if you get a syndactyly, you have to get an x-ray. You may get something like this, just to be warned about that. So I opened up the hand. I saw a single vessel going to 3 digits. Raja, what would you do? I heard that in your talk just now.
Yeah, I think because whichever you think the other side is safer, keep the vessel on that side and then make only one division. That's it. Don't separate them all. Yeah.
So what would you do? You will keep it as it is and separate one finger out, or what would you do?
The one finger out, only one finger out, only one finger.
So what I did was I staged it. I separated out to here, and then I separated again, and I did warn them that we have to do some corrective osteotomy later. But again, this is just to highlight the point that you may get abnormal vasculature. Don't rush in the separation. Take it slowly. I am sort of rushing a bit because I want to cover more cases. So this is an 8-year-old girl, left hand, isolated macrodactyly of the middle finger. Again, contribution from Bangladesh. I think you can see repeated debulking. So Scott, what would you do for this?
Yeah, we would remove that long finger. We would just tell the family that function trumps form, and it's had surgery on it. It's just going to get worse. And then we would deal with the residual problem with the index and ring finger.
Would you do an index transposition?
Yes.
You would, okay. So I think according to the parents and the doctor who submitted it, they refuse an amputation. So Raja, what would you do? So this is all the picture I have.
Yeah, I think the refuse amputation, that's the biggest problem. So I would like to do as to what I showed in the case.
So you do that technique?
Yeah, sure, I think. It's just very interesting to know whether there was a movement in the PEP joint. If it's there, then we can go ahead and I think there should be some movement. And ideally, as Scott said, if they accept for reamputation is fantastic. If they don't, I think I'll do the same way as I presented.
Okay.
Yes.
So,
really happy. Yeah.
Yes, hi, who is that?
Can I ask a question?
Yes.
Not in this case, but in the case of macrodactylys, does any of the panelists have experience of epiphyseal fusions in the much younger hand to address growth discrepancy in these long digits?
Yep, and don't do it too early is what I would say.
Yeah.
I think, you can do epiphyseal fusions, but your big problem with these isn't the length, it's almost always the width. And they'll carry on growing, and they'll carry on growing even past skeletal maturity. And so if you make them short and fat, they look worse than if they're slightly long and fat. So I'm inclined to actually leave my epiphysiodesis a little bit longer than the other side or the parental side, because short and fat is really bad.
I
So
agree.
for this case, Jill, would you do epiphysiodesis when the finger reaches the size of the parent's hand, or would you amputate?
This one, if I could, I'd amputate. If they wouldn't let me amputate, then I'd do a DIP joint fusion. I'd be doing some shortening at that stage, but you don't get much shortening. But I'd be going a little bit beyond the size of the parent, because what I want at the end is this to be very slightly longer than the parental one at skeletal maturity, because it's still going to be fat. If I do a DIP joint fusion as well, I can also thin the middle phalanx and the distal phalanx significantly at the same time, so that it's mainly proximal where the excess bulk is.
I want to quickly show this case. So want to ask the panel, forget about the syndrome. What would be your surgical plan? How many of you think that you would keep this? How many of you would amputate? Anybody would keep this and debulk it?
Amputate. Re-amputation.
Amputate. Okay, so yeah. So thankfully, this is what you all decided. So I did a ray, and I think after today, after Scott's talk, I may consider an index transposition as well. But just want to highlight how good the hand looks after you remove this digit. I think, yeah. Okay, this is another contribution, I think, from Bangladesh. 17-year-old girl repeated macrodactyly debulking of the index, middle, and fingers and thumb. Any syndromes to consider?
Well, she's got a PIK3CA related overgrowth, doesn't she? It's only a question of whether she's got cloves or any other problems.
Sure. Okay. Scott, what would you do for this?
So we would remove the index and long and save the thumb.
Remove the index and the middle and save the thumb.
Yeah, I'm sorry, index and middle, and we save the thumb. So the thumb would oppose against the ring and small.
Okay. Raja?
Yeah, remove the index and middle. And even if you index remove, then the thumb really doesn't reach them, because it's gone over there. So after that, you really have to take a lot of skin from the volar side. Like a dermodesis, we need to get the thumb inside, and then do an osteotomy. Only then, because if you just only removal, I think they stay back far away, and then the thumb doesn't come and meet it here. So I would take a lot of skin so that it becomes in.
Okay, great. I hope we haven't. Ask the panel, any of you would treat this 37 untreated macrodactyly finger?
No. This we could treat. I think this is.
Can anybody debulk this?
Has it got any vascular problem?
Sorry?
Has it got any vascular problem? This patient? Any vascular
not,
problem?
Not that I know of. I haven't got more information.
Yeah.
No.
37-year-old, I think we'll just leave them. We'll talk to them a lot and then leave them.
You just leave them.
Yeah, 37.
That we all agree with that. Okay.
That is because of the age.
Yeah. You want to know what functional problems he had. The older patient coming to you without any functional issues, particularly adolescent or older, you have to think very carefully about before going into surgery.
Shilu, this was your case. You said that she came in for other problems, and you saw a great photo opportunity.
Yes.
So I don't think we're gonna do anything. Okay. Macrodactyly, the second and third toe. What would you do?
Amputate. Yeah.
Amputate.
Foot, amputate. Foot is amputate.
Hey, wait, one quick comment about amputating on this foot. It's really good if you prep and drape both feet. So if both feet are prepped and draped, you can compare the right foot to the left foot at the time of your surgery and try to get them equal size just from a shoe wear standpoint.
Okay.
And the other point in relation to that, if you have one, you'll always get a lot of bulk on the sole, almost like a rocker bottom sole, because there's so much bulk and it's very difficult to get it down in small enough. So as they grow, watch them, because they might have normal leg length, but you may actually get, if you've got a really bad one, you may get actually an inch or, 3 centimeters, I meant 20 centimeters, 3 centimeters difference in length. And so actually you can do an epiphysiodesis on their bones to actually get their leg length the same, because you don't want them limping, you don't want them to end up with hip problems, knee problems and back problems because they've got a significant leg length difference because of the soft tissue.
Okay. Now we're going to come to the end. I really want to squeeze in this case because it was submitted yesterday. This is a 15-month-old boy. It's from a doctor in Nigeria. The antenatal history is maternal bleeding at 2 months. I'm not sure whether these are relevant. Treated for malaria, given amoxicillin, no facial features as far as he can see, normal developmental milestones. The child can stand. The child has transverse errors of both upper limbs and abnormality in the left foot. So these are all the x-rays I have. As far as I can see, the right foot is okay. This is really just to encourage the participants to send in your cases, because we will be discussing this as much as we can. Now, the surgeon's question is this: is this a funny gene, or is this amniotic band syndrome? And the mother's questions are this, which is very important: why did this happen, and what possibilities are there with functional prosthesis? So, Jill, do you want to go for the first one?
I'm not a geneticist, you know, but this doesn't look like amniotic bands.
Oh, I mean, I think that we can conclude. So we're using our eyes and our knowledge, we can conclude this is not an amniotic band syndrome, and therefore is a genetic thing of some sort, yeah?
And the time at which she had malaria could be related. I think not the amoxicillin, but the fact that she was very ill early in pregnancy.
Okay.
Could be righted.
I guess this highlights one of the things, you know, what are we going to tell the mother? Is it because of this and that? It's a very difficult thing to handle. Raja, any thoughts on this? Or maybe more, or anybody? How would you answer the mother?
I tell them we really don't know. I think that's what we really tell them. And the next question they ask is, will my next child will have a problem? And that is the biggest problem to answer. I really don't have any answers for that. And functional processes, I think we should get these children with functional process, but then they will be expensive. I don't know how they can afford. And even these children, if we leave them, I have children like this, they surprisingly they do well. I think they start using both the hands and start writing, and they do almost everything they do, even without anything.
Okay, Scott, any thoughts on the lower limb, the left foot?
So just real quick, I think the bleeding is important, and if you look at the data from Brazil, where people would take Cytotec to abort the child, if they bled but the child didn't abort, they would end up with these type of limb deficiencies. So I think the bleeding, although we don't know the cause of the bleeding, I think it is relevant because it led to bleeding in the AER, which led to defect of these 4 limbs.
Okay. And want to give any thoughts on the prosthesis? Would you leave the foot alone when anybody do anything to the left foot?
It looks like a good weight-bearing end.
Yeah. Okay.
Can I just add one thing, which I think is important? We quite rightly are dealing with parents who bring their children. And quite rightly, we talk to mothers particularly, who often feel an awful lot of guilt because they've given birth to a child with differences and deficiencies. And in the vast majority of cases, certainly those that come to my practice, they haven't done anything, and they haven't not done something that might have made this different for the child. And I think it's extremely important that we emphasize to the mother early on in the consultation that it's nobody's fault and it's not their fault. Now, that will not take that guilt feeling away, but it will hopefully alleviate a little bit of that so that they can help make the appropriate decisions for their children's progress.
Great, thank you. I'm going to stop the complex case discussion. I hope you've enjoyed it. I do have another case quickly, just as a taster for part 2. So this is what we will be looking at in part 2, one of the topics on thumb duplication. So this is a great case. This is from Kemi from Nigeria. So just to make you think about what you will do for something like this. It's not all going to be easy cases, guys. Now I'm going to wrap the whole thing up now. What can you see? Can you see the slide with the feedback forms? Is that what you're looking at? Okay, great. So
You stopped.
You've frozen, wait.
You stopped, way.
The session, but
We can't hear you, way.
Okay, let's give Wee a minute or two to try and just get back in. I think he's having some technical difficulties.
In the meantime, I'll just say thank you very much, everyone, for coming and attending. Thank you very much for all the speakers who are absolutely excellent. And I really enjoyed, in particular, from Ethiopia and Nepal. So thank you for joining in and helping us. And it is just an absolute pleasure to have people from all over the world listening in and us exchanging our knowledge. And I think that's just fantastic. And I'm really grateful for Wee for giving us the opportunity to do that, and for the BFIRST and BSSH. And I hope we can continue to collaborate, not only in 2 weeks' time when we've got the next symposium, but in the future as well, because I think it's been fantastic. Now, I'm sure we'll want some feedback. I know we've got lots of feedback on the chat. And we better keep that, but I think he'll probably want some more formal feedback as well, and hopefully he'll be coming in here any minute.
yes, I'm back again now.
Sorry, Wee, I took over in your absence.
Now, quite a few people have asked me about how to download the app. We will be sending out the links to the app, okay? So, and lastly, just to say, save the date for part 2, which is on the 25th of September. I hope you've enjoyed today. If you enjoyed today, I think you will also enjoy part 2 very, very much. Just a quick overview. We will be looking at thumb duplication. We will look again at congenital hand surgery around the world. We're going to hear about congenital hand surgery in Vietnam and Nigeria. And Don Lalonde will be speaking to us about Wallans in pediatric hand surgery. We will look at various malformations, all these very, very interesting topics presented by various people. And again, we will have another session on complex case. So really want to encourage you to sign up for part 2 and send in your cases. Okay, so that leaves me to just thank all of our speakers and panelists and moderators, and to thank all of you for staying to the end. Fantastic. I know it's very late for some of you. And thank you very much for joining us. Thank you.
Thank you so much. Bye-bye, Scott.
Bye. Thank you.
Ruth. Bye-bye.
Thank you. Bye-bye.
Thank you very much. Bye-bye.
Bye.
Bye.